So we're going to get started here because we have a jam-packed schedule and I talk a lot. So I welcome all of you that are here with us today for the Global Refractive Surgery Summit, the first ever being held that I know of. And correct me if I'm wrong, but the first initiative that is in collaboration with the rock star organizations of ophthalmology, and that is the American Society for Cataract and Refractive Surgery, the Refractive Surgery Alliance, and the Himalayan Cataract Project, Cure Blindness. We have absolute rock stars. I mean, when you talk about who we have here today, I didn't even put names on there because facial recognition is all it takes to know that everyone here is a pioneer in ophthalmology and has set the pavement for all of us to follow in your footsteps. The goal today is that we are going to bring forth a discussion. It's a simple discussion that is going to ask the question, so when we say something like, today is a bright, sunny day in sunny blank, the answer, even in India, is going to be California. Am I right? Sunny California. And that's because we all come in with a particular bias, a particular mindset of what something should be like, right? And here, refractive surgery, throughout my training and beyond refractive surgery has this nuance that is not something that is considered as a curable tool for blindness. And that is the question that I have for all of us today is, can it be used as a curable tool for blindness in the fight towards the global pandemic, epidemic, if you will, on vision impairment? And if so, how do we do this on an individual basis and on a collective basis? So I am going to introduce in a few minutes Dr. Jeff Tabin, who is our keynote address. We are also very lucky and fortunate to have him and Dr. Paul Farmer to both have accepted the keynote address positions. And we had two until we received the note that Dr. Farmer had passed away. And this is only to bring inspiration to us. This is not a sad note. This is a moment to say, look, his life reflected action, and his life has taught us the idea that we need to move faster than we have moved. At least that's the lesson that I learned. Life's too short to go at a slow pace. And with that, I'm going to hand it over to Dr. David Chang to talk to us a few minutes on behalf of the American Society for Cataract and Refractive Surgery. We also have Dr. Ernie, who's representing the ASCRS. We've got Dr. Jeff Tabin and Dr. Matt Oliva, who are representing the Himalayan Cataract Project, Lisa McIntyre and Guy Kazarian. And if we can just have a word from Dr. David Chang on behalf of all of us.
Well, yes. First of all, Ashiana, congratulations and thanks for your leadership in creating this summit. The ASCRS Foundation is so proud and happy to be collaborating with HCP and the Refractive Surgery Alliance. I think refractive surgery clearly is a big part of what we do to improve the quality of the lives of our eye patients. It's an unmet need globally, and as I think we'll see today, there's a real opportunity here to have it generate cost recovery in ways that support other needed areas for eye care. So again, we're just so excited to see this summit and welcome everybody.
Thank you very much, Dr. Chang. On that note, we're going to go ahead and start with a quick video on the life of Dr. Paul Farmer. It's a 3-minute, 45-second video commemorating his life, and then we will hand it over to Dr. Jeff Tabin for his keynote address.
First question is very simple, Paul. State your name and your title.
I'm Paul Farmer. What do I say next? MD, chief strategist, PIH, I love that title, by the way. Founder, I'm proud of that. First medical director. I wasn't qualified for that, but hey, I did my best. So there's some titles.
I was driven after 1983 by this raw experience, and a very good one, is how do we make the work we're doing collectively matter?
We didn't know what we were doing. We didn't know how to build a clinic.
Ça y est, architecte, oui.
Non, bah, je dis c'est pas vrai.
Allez.
The biggest struggles of my life have always been around the fight for social justice. What could be better than being an activist? It's something you're doing because you want to do it. It's not a job that you're paid to do. It's something you choose to do. So I think that's a big deal, being an activist.
None of our patients have died. One person died a few days after starting therapy because we started too late. And isn't that the lesson of the last 20 years? We started too late.
If I break my leg, you're gonna fix it. We really believe that all people have equal value. And we can all build healthcare systems that are compassionate and merciful. To me, that is about hope, and it's about rejecting despair. This work that we are so lucky to do is not just about diagnosing the problem, but about responding to it. And when you do, with even modest resources, the return on that investment is just incredible.
This effort is motivated by love and should be informed by compassion and expert mercy.
Is it okay to write bravo in a medical chart? I mean, you gotta love this job.
I can't imagine doing anything else with my life.
Allez, mes amis.
Merci bien. Merci, maman.
Bien content, Weno?
Merci bien.
Merci pour l'accueil là. Ok, chérie. Bye.
Love and compassion, and that we don't have enough time. Those were the three take homes I took away from that video, and from the life of Paul Farmer. And we have with us today Dr. Jeff Tabin, who is our keynote address. He's the co-founder of the Himalayan Cataract Project, co-founder and chairman, I should say, professor of ophthalmology and global medicine at Stanford, publishing more than 45 peer-reviewed articles, 2 books, and a dozen book chapters related to his work in ophthalmology and the developing world. He's a mentor of mine. He's been my role model from my days in residency on. And a lot of what I do today is from afar here in India because of him, because I knew that there was someone out there that can climb every mountain and beyond, and can reach new heights. And Jeff, I am just so grateful that you are our keynote address today. Without further ado, Dr. Jeff Tabin.
Well, thank you so much, Ashiana, and hello to everybody. It's a little sad for me giving this keynote address because, as you may have heard, it was supposed to have been my friend Paul Farmer giving this address. And I spoke to Paul at length about what he was going to be saying. And really, he was going to be highlighting the importance of eyes in global health and also the importance of refractive care within eyes. And Paul was a wonderful guy. I mean, he just was a nice person. He was compassionate, he was passionate, and he really cared. And he really changed the paradigm of global health in a way of focusing big public health issues on the individual patient. When Paul started, a lot of people were saying it's impossible. There's too much to do. Let's start with just getting clean water. And Paul said, no, these are people in Haiti. We need to do everything for each individual person. And let's make it cost effective. Everybody's important. When he started working in HIV, he really changed the paradigm. The World Health Organization's approach was basically give everybody a condom and prevent the spread. We'll let everybody who has HIV die, and then there won't be any more HIV if the people don't spread it. And Paul really changed the paradigm, saying, hey, every individual person is the most important person. And if it's too expensive right now to give antiretrovirals, let's figure out how to bring the cost down. The same thing with multi-drug resistant tuberculosis. And everything he did, it was both the grand scheme of how can we reach everybody, but also how can we do the best for each individual. And it really was social justice. And what Paul was going to speak about today were priorities in global public health and global health care and the need for nutrition and how we're dealing with every crisis from the current pandemic of SARS, COVID-19, to how we're dealing with multi-drug resistant malaria, maternal health, and childhood health. And one of the things he was going to conclude with was that within the realm of health, vision is so important. And when the UN Millennium Development Goals were brought out, unfortunately, vision wasn't included. And Paul was one of the very few advocates who were involved at the level of making those decisions who said we should have vision in the UN Millennium Development Goals. And now with the new onset of UN goals that are saying the overall well-being of a person is part of those health goals, vision actually has to be part of it. And really, vision is the low-hanging fruit of global public health. And that was going to be the conclusion of Paul Farmer's talk, which, as I said, for those of you who don't know, he died of a sudden heart attack in Rwanda about 3 weeks ago now. And I had actually spoken to him about this talk about 1 week before he passed. And his conclusion was going to be that there's an epidemic of global blindness, with 39 people blind, but 80% of that blindness being easily treatable or could have easily been prevented. And that 90% are in the poor places in the world. And the impact of people is devastating. And there are 19 million children who are severely visually impaired, who with refraction can live a completely normal, healthy, productive life. And the other thing that really irks me when we see these large organizations and how we're getting funded, for example, the Gates Foundation says they're not interested in interventions in things that aren't life-threatening. But several studies have come out showing that once you go blind in the developing world, in the poor countries of our planet, life expectancy is 1/3 that of age and health matched peers. And Taylor published in Australia showing an increase in mortality when people lose their vision in Australia. And for blind children, it's worse. In blind children, the ones who go blind are usually in resource limited places where there's food insecurity and they have total caloric defect deficiency. And but the ones who go blind from vitamin A deficiency, among those peers who have the same nutritional challenges, the blind children die at a much higher rate. And the other thing that doesn't really get discussed enough is the economic impact of low vision and blindness, and people who can't function and work at a job simply because of a refractive error or because they're blind. And that actually takes not just that person out of the workforce, but also another person. And this often is a child who has to lead their father around by a stick and take care of their mother or take care of their grandmother, and they won't go to school. Or a child who has to go work in the fields at age 10 to feed their family in a subsistence agrarian economy and will never go to school, and the lifetime loss of earnings of that child because they can never work. So blindness really leads to and perpetuates poverty on our planet, both for the individual, the family, the community, and the country. So blindness really needs to be a priority. And when you look at the prevalence of blindness, you see that it really is centered in Asia, South Asia, and Africa. And one of the other big challenges that we have are those same areas are where we have less healthcare workers. Where David Chang and I live, we probably have an ophthalmologist on every block. In America, I think the statistic is now one ophthalmologist for every 18,000 people. But much of Africa, it's really devastating. But also there's a shortage throughout South Asia. I just returned 2 weeks ago from South Sudan, where there are 3 ophthalmologists for 12 million people. 3 ophthalmologists for 12 million people. And how do we figure out what are we going to do with our resources? What are our priorities? Well, again, the priorities have to be intervening in the low-hanging fruit. And what is the lowest hanging fruit? And I'll get back to it in a second, because I'm going to talk about some other programs, but the lowest hanging fruit is refractive error. The leading cause of what we would call in America legal blindness, 2200, is lack of spectacles or lack of refractive surgery. Cataract is then the next leading cause of complete blindness, and it's completely reversible. Glaucoma is difficult, but trachoma, onchocerciasis, xerophthalmia, these are public health issues that we should be able to really do something about. And it's just a travesty that those diseases still exist to the extent that they do. So cataract is the #1 cause of overall blindness. And I think we can learn a lot from some of our programs of how we've addressed cataract into how we can address refractive error. But cataract is refractive surgery. I mean, we're taking a lens that's not focusing, and we're changing the refraction and getting people to see. And certainly, the way we practice in America, cataracts in children is one of the most efficacious long-term fixes that we can have. But as I said, cataract really is refractive surgery. Overcoming trachoma, it's really a public health issue. Getting clean water and azithromycin to every community. The same thing with xerophthalmia. It's just distributing vitamin A, and it's possibly the most efficacious intervention in all of medicine, 75 cents per child per year to prevent a child from going blind. And same thing, there are great programs for onchocerciasis. So let's talk about just refractive surgery now. First, the refractive cataract surgery. We need to give really good quality cataract surgery to all the people on our planet who can go from complete devastation of their lives to a perfectly normal life with a cataract surgery. And the joy is just palpable. And it really is, refractive surgery. And one thing that needs to be focused on, I think, in a lot of our programs in some of the lower resource countries is making sure the refractive outcome is similar to the refractive outcome we try to give to our patients in the more developed world. One of the other interesting things about cataract surgery is the ones who are totally blind are often ones who can't afford to pay. And when you start looking at the numbers, when you start operating at 2,200, you can see two lines down the eye chart, or what we in America give benefits for being legally blind. All of a sudden, it's 60 million people who would benefit from cataract surgery. And if you start operating at the level where I certainly start operating in at Stanford, and when someone's having trouble driving at night, it's 8 times that number. But one of the things we've been working on doing is harnessing those patients who are still working, who can afford to pay. It's been called at Aravind compassionate capitalism. And we've spread that into Nepal, where paying patients are subsidizing the free care for the poor. And we have models where we're doing very high volume cataract surgery that's now extending towards the poorest of the poor. So the poorest of the poor get the exact same quality care, and it's being subsidized by the paying patients who can pay. And refractive care is really set up beautifully for that same kind of model of compassionate capitalism. So the 2 points from cataract surgery are how we can do high volume surgery, bring down the costs, and use the profits to pay for free care for the poor. And similarly, that cataract surgery has to be refractive surgery. And then the WHO came out with a report on world vision in 2019. And again, you can see that the huge, huge elephant in the room is unaddressed refractive error. And then at the bottom, you see unaddressed presbyopia. And there are about 1 billion people on our planet with visual impairment that could be better addressed. And there are also a lot of people in the lower resource countries who are having sutureless extracapsular cataract surgery, who are having induced astigmatism and not having their best possible vision because of refractive error. So just giving spectacles is a great thing. And how do we figure out, as refractive doctors and as eye care specialists, how do we figure out how to reach the most remote people? We need to figure out how to get a much better, more robust and less expensive autorefractor, how to be able to bring in the ability to give these people spectacles. We need to do something much better for presbyopia. And as the population increases, these problems are just increasing as the time goes on, and particularly presbyopic issues, but also as we have so many myopic children who are moving into their teenage years and will be soon moving into young adulthood. And how do we keep them productive both in school and in life? And the World Health Assembly came out saying they want a 40% increase in coverage of refractive error by 2030 and a 30% increase in effective cataract coverage. 2030, that's a long time. I think, as Ashiana said, there's an urgency, and we really need to all work together and start doing things now. It's early in the morning for me, but do you guys know what time it is? The time is now. The time is now. And this is our time to really get together and see that every child in every poor country is able to get spectacles. And as people get older, refractive surgery does have a huge place, both for the elite of the country who are willing to pay to have their refractive surgery, but also as a way to fund refractive care. And it should be a completely integrated system in my mind, where we're giving refractive care people. There's a wonderful system that Dr. Heiwa I always forget how to pronounce his name. It's either Heiwei or Heiwa in the Manchurian province of China, started a program where he has refractive clinics, and people can come in and they have both the spectacles available and the high volume LASIK. And when you're doing the refractive surgery, the profits, again, can go towards helping with the poor. And the first program that really set out to do that I know of was at our hospital in Kathmandu, the Tilganga Institute of Ophthalmology. We sent one of our young superstars, Kishore Pradhan, to London Vision Clinic, and he worked with Dan Reinstein, who really mentored this program. And the idea initially was to have high volume refractive surgery, have it available so that a certain percentage would be on the destitute, people who work in a area where they can't really wear spectacles, people lose their spectacles. So refractive surgery might be a great option for poor people, and that it would also be a great program to subsidize also all the refractive care and giving spectacles. It really did its job, but unfortunately, a lot of the money, things changed in Nepal, and the Nepal economic situation mandated that we needed to use some of the money to support other aspects of the hospital. And it became very profitable. It did everything we wanted it to do, except launch this huge refractive program. It tended to fund more outreach cataract surgery and funding of more nurses, and increased. It was right when there was a oil embargo, and the Indian government blocked the trucks coming in from India, and prices of oil went way up. And unfortunately, it subsidized other things, but it really set the model and set the bar. And I really believe that we can use refractive surgery. And one thing to backtrack on, refractive surgery really is the low-hanging fruit. And there are huge numbers of, billion people who have refractive error. But when it breaks down, one of the ways Paul Farmer used to look at things, which I really admired, was that these are each individual people. And when we do LASIK for someone, they're no longer a statistic. They are 100% cured. They're not part of that 1 in a billion. It's one of the few things, cataracts and refractive error are things where we can completely cure people. And people can see the beautiful views of their world. They can function, they can work. And I think it's so exciting we have this panel here today that Ashiana brought us, and with thanks to the ASCRS Foundation, and to be able to address and figure out how we can all work together to figure out how we can do something for the 1 billion people on our planet with refractive error. It's the low-hanging fruit, and it's something we can do. And I'm very sad that I'm giving this lecture and not my friend Paul Farmer, but his conclusion would be the same, that we have lots of work to do, and the time is now, and let's get her done. Thank you very much for inviting me, Ashiana.
Thank you very much, Dr. Tabin, for being with us. You have highlighted aspects that are going to be brought up in every thread of the segment, part 1 and part 2. So thank you for giving us an appetizer to the interesting discussions that we're going to have ahead of us. I am now going to move forward to the next segment, which is a foundational talk and topic, and that is the current state of refractive error, a global overview. It was more than a decade ago when I had interned at the World Health Organization in the early phases of its global burden of disease study. And my focus, my responsibility was on the team of blindness and vision impairment. The Global Burden of Disease Study was a systematic review, meta-analysis of population-based surveys of eye disease. It was performed from January 1980 to October 2018. Hierarchical models were used to estimate the prevalence of moderate and severe vision impairment and blindness. Moderate to severe vision impairment we defined as presenting visual acuity from 618 to 3 by 60, and blindness as presenting visual acuity of less than 3/60 or less than 10 degrees of visual field around central fixation. Data was further classified by cause, age, region, and year. And the goal? Well, the goal was to compare the results with that of the World Health Assembly Global Action Plan target of a 25% global reduction. This was from 2010 to 2019 in avoidable vision impairment. Avoidable vision impairment was defined twofold as uncorrected refractive error and cataract. We can see here visually with moderate and severe vision impairment to the left and blindness to the right, that the sheer proportion of moderate and severe vision impairment due to uncorrected refractive error and cataract indeed account for the large majority. The key takeaways from the global burden of disease study were that undercorrected refractive error is the third leading global cause of blindness in those aged 50 years and older as of 2020. The global crude prevalence of avoidable vision impairment and blindness in adults ages 50 and older did not change between 2010 and 2019. Additionally, age standardized prevalence of avoidable blindness decreased. Avoidable moderate to severe visual impairment showed no change, and the number of cases increased for both avoidable blindness and moderate to severe visual impairment. The results suggested that eye care services contributed to the observed reduction of age standardized rates of avoidable blindness, but not to moderate to severe visual impairment, and that the target in an aging population was not reached. Global trends that we need to take into account in terms of epidemiological transitions include the rising socio-demographic status, greater life expectancy, an increasing average in population age, and the shift in disease burden towards non-communicable diseases and disabilities. And what other disability are we talking about today but visual impairment and blindness? Dr. Guy Kazarian's favorite article of all time, the Lancet Global Eye Health Commission on Global Eye Health Beyond 2020, this study identified the sustainable developmental goals, studying 29 different studies as it relates to eye health. And it identified direct and indirect benefits from providing eye health services on the sustainable development goals of the United Nations. Those that were direct, as you can see here, were relating to poverty. Number 2, education. Number 3, equality. And number 4, sustainable cities and communities. As Jeff already mentioned, visual impairment by the global burden of disease echoes the same, with the overwhelming burden occurring in South Asia, Southeast Asia, and Western Sub-Saharan Africa. So when we talk about solutions and more to come as the discussion rolls forward with uncorrected refractive error, we've got glasses and contacts, and we've got refractive surgery. But what are we doing about it, I say? So the current state of refractive error management in glasses, Jeff brought up the 2021 statistics, but as of 2015, only 37 million was spent on delivering eyeglasses to people in the developing world. And my friends, that's less than 1% of the amount that's used in global health issues. So we have a long ways to go. And one aspect that we are bringing up today as well is refractive surgery. And when we look on the overall global scheme, we are very, very, very proud of the sites that have really integrated refractive surgery. And I started at the bottom as a tool for curable blindness, in particular in Cusco, Peru, by Dr. Nathan Henson, Christian Becker. We have Africa with Matt Oliva, Jeff Tabin, Guy Kazarian, as well as Lorenz Kotze in Cape Town, and Nepal, the wonderful work by Dr. Dan Reinstein and Dr. Kishore Pradhan. And I am really happy to say, including Christian Becker, who is an attendee today, that 100% of the people here that are shown on this map are present with us today. And so we have a lot of work ahead of us. We have a lot of discussion ahead of us. I put forth the facts, and knowing that this is the start of a potential movement, potential movement in our own backyard to do something more for the people in our area, be it providing additional refractive surgery to, say, 2 more people in the month that perhaps cannot afford, to moving ahead and dedicating oneself to one of these centers, or perhaps building your own site. And here with the Lancet Global Health article, I added in 2022 global refractive surgery on the map of our timeline. And with that, I thank everyone for their participation today. And I am going to bring up these points with our key panelists and moderators in section 2. But I am going to move forward in this discussion that I call it a public health forum and discussion with the next speaker, who is Dr. Dan Reinstein. Dr. Dan Reinstein has a wealth of knowledge, experience firsthand in making the waves in Nepal. I'm not speaking off of any particular slide, Dr. Reinstein. I'm just speaking from my heart here about you. And he is perhaps one of the busiest people to get in contact with. And I am just so honored that you have taken time out of your busy schedule to be with us today, not only to talk about the ethics of refractive surgery in the developing world, but then later on to talk about training in the developing world. So without further ado, I hand it over to Dr. Reinstein.
Well, this is precisely the sort of thing that I like to keep myself busy with. So thank you. And thank you, Jeff and David Chang, and well, all of you here who have been participating in this concept for all these years. Now, you gave me the title of Ethics of Global Refractive Surgery. I thought about that if I was really going to talk in this way, I might actually insult a lot of people, which, you know, many of you who know me, I don't seem to be particularly bothered by doing that. But I thought I'd couch it a little bit differently as I'm getting older and perhaps a little bit wiser. These are my financial disclosures, and, you know, how do they relate? Well, yeah, I kind of was quite involved in developing SMILE, which I'm going to mention is one of the key, I think, ingredients in addressing global refractive error. But, you know, I just want to say that before anything, I graduated from medical school here in England from Cambridge in 1989. I did my house jobs. And then I did an emergency medicine residency just for a year because I wanted to become a real doctor. And I knew I wanted to do ophthalmology after that. So I was desperate to think of a way of doing some research of some kind to, you know, help me get into a residency. And I latched onto the fact that pinhole vision can be done by any doctor. It's not like you have to have a medical qualification to do that. And so I had this idea of looking at all of the elderly patients coming into the emergency room and seeing whether they had their spectacles with them or not, and then what their pinhole vision was, and then to try and define the difference between their spectacle corrected vision and their pinhole over the spectacles as a correctable, undetected visual acuity deficit. So a QVAD. And so I co-opted a bunch of my co-residents, and I said, if you get one patient to fill out one form, you can have your name on the paper, and I'm going to put you in order according to how many forms you got filled out for the study. Then I got masses of help from my consultant, Robin Touquet, and Dr. Challender, but Richard Wormold, who is an ophthalmic epidemiologist, who was on the Global Lancet publication as well. He was really my big mentor in trying to put this together. We eventually published it. So I've had an interest in this idea of people going around without correction for quite some time, as you can see. And here we are, January of this year, where I was fortunate that the Lancet was very strict about not taking my response to their publication as a letter. They said that I didn't make the deadline of 2 weeks, but the article is 60 pages long. It takes 2 weeks to read it. It was my response. They said, sorry, it's 2 weeks. I said, no problem. So I wrote to Brad Randleman. I sent and I said, hey, how about an editorial? He said, next month if you want. This is great stuff. So Guy will he can post the PDF onto this group if you like, for you to download this. I think it's kind of summarizes what I'm going to tell you here. But this Global Health Commission is awesome because you've got a group of people who, are professionals at assessing quality of life and, all of the metrics, the economic metrics, and all these things that lead to the ability to justify the expenditure on healthcare. And we're talking about refractive error. And, it's interesting that although the 2020 project in 1998 said that, well, they hadn't even had refractive error on the map. I wrote to the WHO at that time, didn't get a response for 2 years actually. But now it's very, very well established that, uncorrected refractive error is a big problem. It's double the problem of cataract, which is not what you'd think if you walked into the WHO 20 years ago. They're just talking about surgical things for the elderly. And the other thing that's come out of this report loud and clear is that refractive error is a problem that affects much more the working population. And those are the ones who are supposed to help develop the economy of an underdeveloped country. So rather than operating on Granny for free because she can't help with her grandchild because her son can't go to work because he has a refractive error, why don't you correct the refractive error of the son, and then he can pay for his mother's cataract surgery. That helps the economy, pays taxes, and then she can look after the child who doesn't starve because the kid's father can go to work. It's a completely upside down, topsy-turvy problem over the assessment of all the NGOs until now. Not to mention that this myopic problem is just going to get worse. And not to mention that now that people are actually considering presbyopia as an uncorrected refractive error of sorts, that adds, quadruples the problem of uncorrected refractive error in the younger working group. Now, this Lancet report was rather it was like a red flag in front of me if I'm the bull, because it talked a lot about the low manufacturing costs of spectacles but there's a problem with breakage and replacement and losing them, and the dog eats it, and you're walking in the mountains and they fall off. And the fact that it has continued funding requirements, and that in some cultures, wearing glasses means you're not going to get a husband because you're a genetic defect. And, this is a problem for, culturally. They acknowledge that it's more difficult to correct astigmatism. Contact lenses in developing countries is difficult for obvious reasons. And, follow up, regular lens supply and all of these issues. So they talk about this as the challenge of correcting uncorrected refractive error. Now, it's extraordinary, right? So they then say, well, given this huge magnitude and given that, we can't expect the universal health care systems of these countries to cover this. It's too big. It's going to have to need help from the private sector. And still they're referring to glasses. And I said, well, and this was my letter to the Lancet, which was like, okay, you've got it absolutely right up to this bit about the private sector. That is correct. But what you got wrong was that what you mean by private sector is you mean refractive surgeons. That's what you mean. Because these disadvantages of glasses and contact lenses are totally eradicated by refractive surgery. And yes, there's a high capital cost investment required. I'm going to talk about that. And yes, it involves training surgeons in a specialty which general ophthalmologists cannot and should not intervene in, but it's a permanent result. And basically 100% of patients are 20/40 with one procedure, i.e. no enhancements. And it's a one-off cost if there's going to be a cost to the patient. And as I will explain, there is a dual purpose to having refractive surgery set up in a developing country. So there was a very good review article by the ASCRS on the extraordinary safety and success rate of modern LASIK. Now, from my own clinic, and I've mentioned this, we have published the outcomes. This is peer-reviewed publications for all of the myopia up to -14 using LASIK. Smile with low myopia and high myopia as well. Hyperopic corrections can be done with LASIK extremely safely and with high efficacy if you have the right technology like epithelial mapping and a knowledge of centration and the right excimer lasers to do it. And mixed cylinder can be corrected as well. And we now know that presbyopia can be corrected exceedingly effectively. There are about 60 centers in the world now doing Presbeyond laser blended vision, which I developed and has been programmed by Zeiss. And obviously there is ICL for the extreme situations, and that's possibly doable as well. I mean, if cataract surgery is doable, so is an intraocular contact lens of sorts. But the fact is that for laser eye surgery, you can approach practically 97% of all refractive errors in a 15-minute procedure that heals in 3 hours. And with SMILE, this is done with, effectively very little follow-up requirements. So the role of refractive surgery, as I said, has this dual purpose. One is that it, does this wonderful thing of permanently correcting refractive error, but it can also, through paying patients, as we proved in Nepal all these years ago, it can assist the local hospital in making profits that can be used for other elements. And we helped Tilganga become far more self-sustaining than they ever would be, because refractive surgery is very profitable. And it's, that's the best of both worlds. And that's why, when I was I started talking about this in 1998 to the WHO, obviously ignored, but like Schopenhauer said, all truth passes through 3 stages, right? Stage 1, ignored. Stage 2, violently opposed. I definitely had that till 2008 when I first met Jeff and said, let's do something in Nepal. And here we are. Stage 3, as described by Schopenhauer, it's inherently obvious, everything, and everyone's on board, at least in ophthalmology now. So this project, you're taking a highly developed system with which Jeff and Dr. Ruitt, developed over decades. The procedure, the small incision cataract surgery, you can do it in the mountains inside a bubble in a school classroom, adapted, and a very, very beautifully, USAID supported built hospital in the middle of fields with cow dung and everything around it, but a beautifully clean, sterilized, modern facility. And so I was very inspired, and I decided to call upon some of my wealthier patients here in London, and I invited them to the Royal Institution, which is this several hundred-year-old scientific institution where all the great, Boyle and all these people gave their lectures. And I said, look, we're gonna launch this thing. We're gonna test if it's possible to spend the money to make this work, because I've been told so many times that it was crazy, and I was just doggedly determined to try it. And I put most of the money in myself because I didn't want to get egg on my face asking others for money. But we established this center with this mission statement, and we were dedicated to the fact that we needed to see whether refractive surgery could be done in a country that was exceedingly poor. And at Tilganga, they already had the systems in place for these specialized people to interview these patients and work out whether they can pay a little bit or pay proper, or where they're not going to be able to pay anything. And that's a sort of psychological test discussion thing. It's not a form they fill out. It's a little interview, and they can work out, those guys, with very high precision who can pay and who can't. Here, we did the finance. All of this is published in our paper in JCRS, but we got a ton of help from USAID, but I put in most of the cash up front, and a couple of patients put in a little bit as well, just to share the burden. There was the old Tilganga Hospital, next to the one that you saw the beautiful picture of, and we sort of, it looked awful, but I mean, there we are. That's what we started with, and with the money from USAID, boom, we turned it into what looks like a modern facility in any modern refractive surgery clinic anywhere in the developed world. And the OR was equipped through, we paid for these lasers, a Visumax and a MEL 80 with the CRS master, with topography guided treatment, with Presbeyond. In other words, Kishore, once we set him up, was operating at a higher standard than anyone in the United States. Anyone. Because he had SMILE, he had a Visumax, and he had a topography guided, wavefront guided, and he had Presbeyond, all in Nepal in 2012, where a lot of these things are still not approved in the States to the extent that Kishore had. He had epithelial mapping, he had back surface screening, phoropters, he had digital charts with contrast sensitivity measurements. This was done at the high end. We didn't want to do this, kind of like quick and dirty. This was supposed to be the same standard as that which we taught Kishore here in London. So we, the percentage of profits that went into, each of the expenses were clearly marked. And as Jeff just said, because of the earthquake and fuel shortages and electricity demands, which were totally erratic around that time, the needs of the hospital became so desperate that actually the profit of the refractive surgery center ended up saving the hospital in some ways. But of course, it diverted from our original goals of being able to deliver refractive surgery to people who were too poor to afford a pair of glasses. We published Kishore's outcomes in a peer-reviewed journal, and they were superb, and I'm going to go through that during the training lecture. And so I think that, we demonstrated that high-quality laser eye surgery can be established in a very underdeveloped environment, Nepal, the second poorest country on the planet at the time. Yes, it requires this injection of capital investment, but we demonstrated that it can very quickly become a profit-generating center and therefore self-sustaining. Our project, was pioneering and risky, and we could have lost all of it, and that was worth taking the risk because it worked, but it would have been worth it if it hadn't worked, because then everyone would have said to me, we told you so. But the fact is, in one microcosm, we did this. And I know that Nathan, who's online here, was inspired by our talking about this to do exactly the same thing at what he was setting up already in the Andes in Peru. I'm going to talk a bit about them as well. And the fact is that SMILE has this potential, because it's a keyhole procedure, it's a 2mm incision. This is it. I mean, this is it. This is all of the benefits of LASIK versus PRK with fast healing, no moving parts, and therefore no flap slip and all these other things that need managing over time. Yes, however, microkeratome LASIK is way less expensive to deliver and exceedingly safe and good if you're an expert trained Hansatome user, for example. So that's not to be discounted, but there we are. And as I will talk in my second talk in the second half of this great symposium, I'm going to talk about the concept of surgeon training, because obviously that is the key to this working. Because if you're opening refractive surgery in a developing country that doesn't have access to this yet or has never seen it before, and you get bad outcomes off the bat, the program is over, because public confidence goes out the window, and it would take you a decade to erase the bad publicity. So training, high standards, best equipment, not secondhand old stuff, the best equipment, the best training, the safety measures, and that's the issue. So, I glean from that what would be the ethical considerations of not doing that. And my message to the 2020 project was that, yeah, you made a lot of progress, but can you please apply the same techniques of Callies and Dallies and all these things that you like to measure, but could you do that for refractive surgery as like a serious option, which is way better than glasses and contact lenses? I mean, obviously glasses doesn't work because cheap glasses have been available for 30 years. And let me see. Oh, half of the global impairment is because no glasses. So it doesn't work. You got the cheap glasses, but it doesn't work. The proof is it's got to be refractive surgery. So you guys need to calculate all this stuff for us, because once you do that, it's going to become patently obvious that this is the kind of investment that needs to go in to developing countries. And it might mean that cataract surgery becomes a paid procedure because now people can afford to do it, like I said, rather than giving all the money to the people who aren't really contributing to the economy and to the growth and sort of the way that onions out. And so, the refractive surgery community needs to be awake, and they need to be excited about this, because yes, it's a very profitable thing to do in the middle of London here, and it's wonderful. But the joy of seeing people who walked around with a -4 their whole life is, I think, somewhat like the joy of taking blind people and giving them sight through cataract surgery. Thank you.
Dr. Reinstein, thank you very much for that wonderful talk. And I think everything is kind of lining up so beautifully in the conversation. You mentioned the WHO, which we didn't get that message, and we should have in time. Thank you for taking the risks that you did, because it's because of you that we are where we are at in this realm of global refractive.
A lot of people involved, but I did take a lot of slaps on the face for 10 years until I met Jeff at George Waring's. Jeff was getting an award at the Academy. I can't remember which one, and which one of the thousands he deserves. And we were at the party, and there was a jazz group there. I was playing saxophone, and Jeff came with his harmonica. And then I'd never met Jeff, and we just got talking. And I said, that hospital in Nepal, have you thought about refractive? Oh, we tried it. Didn't. We shook hands. We're doing it, okay? And that was Jeff. Yeah, remember that? That was like we have a. Anyway, so there's a lot of resistance out there, but judging by the 103 participants on this panel here in this call, we can see that we've definitely made a lot of headway on exciting people about the fact that refractive surgery is not a luxury product. It is the opposite. It was developed by Wall Street money on the richest and experimented on the richest people. Right, the early adopters in the U.S. with those microkeratomes that were totally bad and destroyed eyes. Yeah, we practiced it on wealthy people, and now that it's a bulletproof procedure, now it's ready for mass production around the world for the people who actually really need it because they don't have access to glasses.
Dr. Reinstein, thank you very much. And I definitely attended the AAO, concert with you and Jeff and loved it. It was lovely in New Orleans. That was my first privy to the duo of the two of you, and excited for many more opportunities to work with you in the near future. I am going to hand it over now to Dr. Guy Kazarian. Dr. Kazarian needs no introduction, as does nobody here, but I'm just going to say a few words on him. Dr. Kazarian is the founder of the Refractive Surgery Alliance. I call him the father of global refractive surgery, if you will. It was him who said, maybe older brother, we don't want to bring up age, older brother, because he is my inspiration. I did refractive surgery, going back to Sunnyside, California. I knew refractive surgery only through, a paying population. And I moved to India in 2017 with the focused goal to take care of the underserved. And that's my purpose, to be here. Now, it was not until I had a discussion with Guy about this concept that, refractive error is a congenital defect. Those words struck so deep that I said to myself, wait a second, this whole part of my training that I'm not using because it's not taking care of the underserved, well, why? And he was the one that instigated that in me. So over to you, Dr. Kazarian, to take us through building a business plan in refractive surgery.
Oh, thank you, Ashiana. That's very generous of you. And it's really a pleasure to be here today. I'm glad that my words resonated with you, and that it's wonderful to see this group coming together. Really compliment you on your leadership and making it happen. Thanks to ASCRS and Refractive Surgery Alliance and Himalayan Cataract Project for bringing this all together. So it's really an honor to be here. And a lot of today is going to be about the why. And I'm going to give you a little bit about the how today. Talk a little bit about some of the mechanics of making things happen. I'm going to talk specifically about building a business plan and the role of a business plan. And it may sound a little dry. I'm going to try to spice it up for you, because I can tell you the business plan is like the heartbeat of a business. And so let me first put up my disclosures, because this looks like I must be a schizophrenic with too many things going on, right? But it's not. This is all one thing. This is all about refractive surgery. My entire life is devoted to having refractive surgery be primary care for vision correction on a global scale. It makes sense financially, it makes sense functionally, it makes sense safety-wise, occupational fitness, everything about it is right. And all of these things support that. I want to specifically thank the Refractive Surgery Alliance for helping with today. And of course, what I'll be drawing on is a lot of the content from the Physician CEO program today. Many of today's panelists, more than half, have been through the Physician CEO program. And it's a very practical way for you to become adept at business. And then also, I want to just recognize and thank the World College of Refractive Surgery and Visual Science. We have Dan Derry, Osama Ibrahim, Dan Reinstein, and others here today who have been instrumental in that. And I will very soon be putting up the Visual Freedom Foundation, which is going to be chaired by Osama Ibrahim and with Dan Reinstein, with Dan Derry rather, working to bring support and financial support for refractive surgery and global refractive surgery. So this is this concept, and this is really what it boils down to with a business plan. This quote by Yogi Berra: "If you don't know where you're going, chances are you aren't going to get there." A business plan simply causes you to map out where you're going, and it causes you to think through the business, think through the plan, and what we're doing. Everything you're doing is a business, whether it's running your practice or running a charity or running an event or an outreach. It is, in a sense, it's a business unit. And so if you think of it that way, and you think of what goes into making it successful, then you will inevitably anticipate obstacles and roadblocks. You'll inevitably identify opportunities and resources, and it will cause you to say, well, gee, I better make sure this doesn't happen, what I call a sensitivity, or let's make sure this does happen, a sensitivity in the positive direction. So having a well thought out business plan for your venture really can help you to succeed. And it can also help you to tell your story, which is important in helping to gain support, resources, and money to help fund what you want to do. It does not have to be a long narrative. It can simply be a PowerPoint. And it should cover, and you can read 1,000 different web sources on how to write a business plan. There's even tools to help you write a business plan. But it should look at your purpose and scope, activities, where you're going to get your money from, your expenses, your resources, your risks, your opportunities. It brings it all together into a narrative, which really for you is a mental exercise to say, how am I going to make this work? And this is one particular tool that we like. It's called the Business Model Canvas. It's available online. You can print this out on a 4x6 or 3x5 kind of big sheet and put it on your wall in a laminated way, and put yellow stickies on it and move ideas around. It's a great brainstorming tool to work and really develop these concepts of what goes into your business and ideate and imagine it. It's very easy and inexpensive to plan on paper. It's very expensive to innovate and plan in real time. So I encourage you to just do this on paper and to think of things through. This is the source for that canvas. It's called Business Model Generation, and it's available online. It's very inexpensive. Now, people get hung up when I talk. I say business plan, they hear accounting, and this is a misconception. Okay, there's so much more to a business plan than simply the financial modeling. Does the financial modeling have to be correct? And yes, it does. You can use a friend to help you with this. You can learn it yourself, but it's not complicated. And really, I'm going to walk through some of the concepts of financial modeling, because if you have the concepts, then the execution of it becomes obvious, and you can certainly hire some of this or borrow some of this from a friend. But basically, in a financial model, all you're saying is, am I going to come out sustainable or unsustainable at the end of the day? Will I be profitable or not? And you may think, oh, wait, Guy, we're in a global health environment right now. Well, Dan Reinstein talked about sustainability. Profit definitely has a role in every business. Profit's not a bad word. We'll talk about that in a moment. But Dan Reinstein's point about changing the equation to have the sustainability be part of your plan, where one part can fund another, where there can be an opportunity for maybe your refractive to fund your cataract surgery. This is what we're trying to get to, and we have to be sustainable if we're going to accomplish our mission. So think about it this way. You bring in money in some way. That might be donations. That might be surgical fees. That might be teaching fees. That might be research fees. You bring in money from sources. You have certain expenses. Then, and in that, we're going to talk about that, but there's what it costs you to do what you're doing. And then there's overhead. And then you have this thing called operating profit before taxes, which can also be thought of as EBITDA. It's a word you'll hear. Then you may pay taxes, or you may not, depending on what your tax status is. And then there's a profit at the end. And that's, it's not any harder than that. People see spreadsheets and they panic, particularly doctors. It's not any harder than that. So this is a very simple rubric, but it is what you see on every spreadsheet for a profit and loss statement, and it's something you certainly can do. When you create this, you then do this over time. You say, okay, this is what it costs to set it up. This is what I'll do in my month 1, month 2, month 3, year 1, year 2, year 3, and I have this thing called a pro forma. It predicts the function of my organization and tells me how I'm going to, where I'm going to break even, where I'm going to start to have sustainability and profit, and what kind of value I'm going to be creating with this. And we have this concept of sensitivities. And so in your pro forma, you'll be looking to drive sustainability, drive revenues, cut expenses, and you'll be looking to different inputs that you can have to do that. The wonderful example of Paul Farmer that Jeff Tabin gave earlier of saying, gee, these HIV drugs are too expensive. How can we lower the cost? I mean, that's the kind of thinking that goes into your business plan, into your business model, into your pro forma. And so when you're looking at these sensitivities, you say, okay, where are our vulnerabilities? Where are our sensitivities? Where are our opportunities to actually do better and increase our sustainability. And that's where you can create the value out of a pro forma by using it to model and to test your hypotheses. Now, I want to directly address this issue of profit, because many people in medicine feel for some reason that there's a separation between our medical mission and our business mission. And I would argue that that is not sustainable, that that's not the case. It's very important for us to always be mindful that what we're doing is affordable. Profit is about affordability. Think about profit as being a measure of sustainability. If I'm making profit, I can keep going forever. If I'm not making profit, if the car is burning more gas than it's able to put in, it's going to stop running. And so profit can be thought of in a very, I think, appealing way as being capturing some of the value you've created so you can create more value. So you're creating value with a business. You're taking resources and money and whatever, time, people, and you're creating something that's more valuable than those resources were worth when you brought them in. That's why you're doing it. You're creating something of more value that's bigger than the input. And the difference is the value created. Profit is the portion of that value that you create that you capture for yourself. The rest of it you distribute to the people, let's say the people you serve, the communities you're in, other places. And that part of it is called consumer surplus that goes to the consumer. The part that you're keeping is your profit. And you can, in our environment, is what keeps the engine running. It's what provides sustainability. So think of profit in a little different way. If you've thought of it as being a dirty word, it's not. It's really the lifeblood of what you continue. So in a laser center, we have a lot of constraints. Dan Reinstein talked about this very well. I won't need to dwell on it. The capital costs are high. If we're going to be setting up a laser center or even an operating room that's a fixed operating room, the capital costs are high. So it costs us a lot to set it up. But once it's running, the ongoing costs are not so high. The surgical expertise is not to be underestimated. Dan also talked about this. It's extremely important that we don't underestimate the training and expertise involved, and recognize that in the context of a situation where you have a high capital cost and low variable cost of cost for doing every procedure, it's all dependent on volume. If you do one case, you'll never have enough income to survive. If you do many cases, you will. So it's all dependent on volume. So there are many ways that you can bring in, many other ways you can bring in support for your venture. Dan's done some of this in Nepal with Jeff Taven, looking at opening up as a research center. There's ways of doing cost recovery and having sliding scales and funding people who can't pay with the people who can pay. There's grants, there's allied organizations, governments, manufacturers, all kinds of people will contribute if you have a compelling business plan that tells a great story, that causes people to be excited and shows that it can be sustainable and can be successful. Quality is absolutely the key, and it's very important that we never put out shoddy refractive surgery. We're dealing with typically younger people who have a lifelong of future ahead of them. To use their eyes, they have to be done well. They have to have very little, if any, complications. And we have in this the opportunity to really drive a lot of value through our work. You know, it's been said in different ways, you know, but refractive surgery, because it's on younger people, has a long-term benefit, which allows us to capture a long-term value for the people we work on. So it's a lifelong benefit for these people, affecting their occupational fitness, their ability to make a living, to go to school, to be safe, to drive safely, to avoid accidents, to all these different things. So the cost justification is really not difficult as you make your business plan and tell your story. And in my mind, and I think in the mind of all the people on the podium today and in the webinar today, refractive surgery is really the financial engine that's going to make eliminating needless blindness a reality, because it will separate us from always depending on outside funding and the largesse of society, who has many other priorities in the world, and lets us create our own engine to fund our own work to make our mission achievable. And that's really where I think refractive surgery fits into this. With a good business plan, you'll know where you're going. we know where we're going. Let's all go there together. Let's accomplish this vision. Let's do it in our lifetime. Time is of the essence. And if I can help anyone doing anything, I've helped a lot of people on this, consult with a lot of people who are here today. Please feel free to call me. I'm happy to help. I don't charge or anything. I'm just happy to do it. This is part of my mission. And I'm so grateful to all of you for being here, and grateful to Ashiana for having this session and launch and this series start, and for us to be working together to accomplish the mission of bringing refractive surgery to the world as primary care for vision correction. Thank you.
Guy, thank you very much for that inspiring, complex talk for some of us. I am myself in the Physician CEO program. I've completed module 1 and 3 more to go. So by module 4, I will learn. I have to say that as the talks progress, I'm realizing that what we are hearing today is not going to be in a textbook, right? We have put together a course booklet that you will see Mary has sent and Guy has sent across in the Zoom in the webinar chat for reference of suggested readings, of objectives to talks. You will not find this anywhere. And I have received messages asking whether this is going to be available as well afterwards. And yes, Mary and Roshni behind the scenes will be sending this out to thousands of people, I am told, after this, for those that have not been able to attend today, as well as for those that have been able to attend today. So yes, there will be a recording. But on the path of things that are not discussed, things that are not in textbooks, I transition to the next segment of this journey. And that is the inner sight meditation relaxation by Dada J.P. Vaswani. Dada J.P. Vaswani was my best friend. He was titled as Saint of the Century. And it goes back to Paul Farmer's video at Life on love and compassion. Everything with love and compassion. And that is the bottom line of Dada's message. I think, as I was thinking about it, I thought about Lisa McIntyre, who's the president of the Refractive Surgery Alliance. Her face came before me because she is someone that represents to me love and compassion. Someone who is leading us forward in many, many ways through the RSA. And each one of you brings that love and compassion to your work every day. That is why you are here today. And so the next phase of what you're going to see is unique to some of you, but for some of you who have attended the Ophthalmology 2020 series, we had provided various different conversations and talks on different aspects, from uveitis to ocular oncology to refractive surgery. You have seen the video before, but here in India, what you all are doing in your daily life in providing contributions to the underserved, we call it in India Seva. And Dada has set up an eye institute dedicated to Seva, service. And so you will see an introductory few minutes, about 4 minutes on the work that's being done at a humble institution in Pune, India, followed by a meditation. And during that meditation, I encourage all of you to take a break, close your eyes, and really go within yourself. We really help other people provide sight in these two eyes, but we need to take a break every day and go within and find inner sight. And that is the inspiration of the meditation. So without further ado, I hand it over to Mary to play the video.
so that man can meet his fellow men, so that man can meet his fellow creatures, not with a bomb or a bullet, but with a blessing and a benediction.
All land belongs to Allah.
God, of course, yeah. Well, it's all. This is holy land.
There is not a nook. There is not a corner.
Yes.
Where God is not.
Everywhere, everywhere. Amen. That's right.
Allahu Akbar.
Allahu Akbar. MashaAllah.
And I tell my friends, I tell them before you retire at night, actually think of all the people who have not behaved properly towards you, all the people who have cheated you, all the people who have deceived you, all the people who have spoken against you, all the people who have spread scandals against you. Call them out by name. Mr. So-and-so, I forgive you. Miss so-and-so, I forgive you. Mrs. So-and-so, I forgive you. Do it out of the very depths of your heart, and you will have a wonderful sleep at night.
Meditation is the key to living a more rewarding, fulfilling, peaceful life. It helps you discover who you really are and what your true potential is. It enhances your ability to face life and its challenges. Meditation is not strenuous or difficult. It is simple and life-changing. The positive energy and healing vibrations of group meditations are tremendous. The force of group meditations has a great impact on every member of the group. Meditation begins with relaxation. Most of our time we are tense without realizing it. We need to relax consciously, allowing the stressed out and exhausted mind to rest. There are many ways of relaxation. Each one of us must follow the one that best suits him or her. I will but indicate to you today one simple method. Sit in a comfortable posture with the back straight. As far as possible, let the back, the neck, and the head be in a straight line. Close your eyes and take a deep breath and exhale. Do this a few times. Let your face wear a smile. Now sit still and breathe normally. Imagine yourself in the loving, the immediate, and the personal presence of the Lord, your beloved. You are sitting at His lotus feet, your arms around His ankles, your head resting on His feet. Say to yourself, here is true rest. Here is true relaxation. Now relax the body, every muscle of the body. To relax a muscle, you must first tighten it and then release it. Remember that all the while you are in the loving, immediate, personal presence of God. We will now move from one limb to another by tightening it and then releasing it. Let us begin. Bring your attention to your feet. Tighten and relax. Legs. Tighten and relax. Buttocks. Squeeze tight and let go. Abdomen. Tuck it in and relax. Chest, expand and relax. Shoulders, lift them upwards and drop them down. Raise your arms and drop them. Turn your attention to your neck. Gently turn it from one side to another. Arms stretch tight and relax. Hands tighten into fists and relax. Relax, relax, relax. Let go, and let God. Now tighten your whole body and relax. Repeat this 3 times. Take a deep breath. Allow your stomach to expand. As you breathe in, hold the breath for a few seconds and then breathe out through your mouth, allowing your body to completely relax. Now rub the palms of your hands together and gently, very gently, place them on your eyes and open them. Continue to smile. Thank yourself for this beautiful gift of a few precious minutes of peace. Slowly turn your gaze around and become aware of your surroundings. This is the end of the meditation. Om Shanti Shanti Shanti.
Thank you, everyone, for going on that journey with us. I feel very, very in silence, if you will, and touched by gratitude. Gratitude to each one of you who have joined us today. We have segment 2 now about to embark on the exciting talks and discussions, and I hand it over to none other than Dr. Guy Kazarian to take us through segment 2. Guy, over to you.
Thank you, Ashtiana. It's a pleasure. I'm very pleased to introduce our next speaker, Lorenz Coetzee from South Africa. Lorenz is known to many of you. He's just a premier refractive surgeon. He's at the Envision Vision Center in South Africa. He's a preceptor for the Refractive Surgery Alliance's fellowship program, but he's also, beyond all the things on paper, just someone with a passion for refractive surgery who the answer is always yes. When you ask Lorenz, can we do this? The answer is yes, and he makes it happen. I just have such admiration for his energy and his drive and his passion, and I think you're going to hear some of that today. Lorenz, thank you for being here. He'll be speaking about refractive surgery in Africa. Lorenz, thank you.
Thank you, Guy. I'm just going to share my my screen here quickly. Yes, so I think on the literature review, like this is what most people have already talked about, and with the Lancet publication came out last year, we know that in Africa, definitely moderate to severe visual impairment is a problem, and I'm not going to spend too much time on this, but just to emphasize the estimated potential loss in productivity secondary to uncorrected myopia is definitely there. Can we go to the next slide? So one should not forget presbyopia, and I know we focus a lot on myopia as well, but for instance, in one of my practices, 80% of my patients that undergo cataract surgery are premium lenses, and this is definitely a challenge to address in the future. And it just these stats emphasize the burden of that disease in Africa as well. Okay, next slide. So there are many barriers to access refractive surgery in sub-Saharan Africa, and I think everybody thinks about cost, but it's actually the big thing here is training and getting the expertise out there, and the low demand then also for products in a country like in Africa, any country in Africa, it makes it very expensive, and then also the import costs. This really limits the service to our patients. Okay, next slide, please. So the thing in Africa is that, as Ashiana said, spectacles, and Dan Reinstein also said that spectacles are not always available, and is there not a different way of addressing it in Africa, and should we not find other solutions? And I think if we can make refractive surgery accessible to the larger community and make it the primary care of treatment, that would be great. Next slide. Okay. So South Africa remains the it is a country of inequality, and like 10% of the population owns more than 80% of the wealth, and we can see this in refractive surgery as well. We have centers which are flourishing in refractive surgery, and they are actually we have access to the latest equipment and to everything out here, but still very few centers, or like next to none of these centers provide refractive surgery to the rest of the population at an affordable price, or even at no fee. Yeah, next slide, please. So currently, these are the centers that I know of. So we have started a center. It's one of my practices in South Africa that we are now earmarked for a community center. And there are definitely some challenges, and we've started already with getting the equipment ready. And but a big thing for us is, as you'll see, the biggest barrier is actually getting the patients there. And so we have made some plans, collaborate with some colleagues, and we are very excited about screening centers that we're going to open up in the near future to actually channel these patients to our practices that can really get the services at a very reduced rate, or at no cost at all. Okay, next slide. So what's the barriers to entry? Well, I think first of all, financial. There's a high initial layout. There's all the click fees, and then the expertise cost, salaries of consultants or refractive surgeons, and even the technical or the technicians are are quite high. But I think for me in South Africa, our biggest barrier here is actually getting the patients to access our services, and there is a fear in community regarding surgery to their eyes. And the other thing that we also notice is that there's a stigma of refractive surgery at academic centers, and that we actually wanted our patient, like we gave them an opportunity to send patients to us, but there's a big hesitancy. And then training, of course, it's a very specialized field, and there's very little exposure during residency. And I think later in the sessions there's going to be a specific talk on this. So most guys are going overseas to get fellowships there. And then, so how do we find solutions here? I think in South Africa, a big thing that we can do is, because of that massive inequality, is we can use cross-subsidization. We can also rely on donations, although that is not very sustainable. Perhaps you can use it for a special project. And what we've actually started to implement now is a tiered reimbursement service where patients get classified with the help of a social worker. It is absolutely important that the center must be self-sustaining. Okay. Next option. Next slide. So patients awareness campaign and social media, and then our big next step is local refractive surgery screening centers in these communities, and where they can actually be channeled to us and have access to these services at a much reduced rate. Yeah, so we'll see how it goes. I think it will go well. And then ophthalmologists, how are we going to train these guys? And the RSA fellowship program is actually that we're currently running is beautiful, and that will be also discussed later in the session. But that has been a real privilege to be involved there, and very, very satisfying. Okay, and then next slide. Yeah, so very, very, very privileged to be involved there. And so a decent art fellowship program is my answer to this barrier to training, and the RSA has taken this bull by the horns, and they are doing awesome work. And as I said, I'm just so happy to be part of this. And yeah, we're having our second bunch of fellows that we train, and they're doing a 2-year program. And yeah, as I said, looking forward to become more and more involved. Okay. Next slide. Thank you. So those are our centers. Much appreciated.
Beautiful. Well, thank you, Lorenz. That was a great talk, and I appreciate your insights and, of course, your involvement in the Refractive Surgery Alliance's fellowship program. I am very pleased to also bring in our next speaker, Nathan Henson. Nathan is one of these people that just is all good about what he's doing. He's got the right motivations, he's got the right skill set, he's got the right connections. He's just really quite a talent for us to have. We're so fortunate to have him in refractive surgery. He's an American by birth and training, and top training in some of the great centers in the country. He did his ophthalmology residency with Baylor Scott and White. But he's moved by his passion for helping people. And he's the head of a charity called La Fuente, which has a hospital, it has an eye clinic, it has an orphanage. It's in Cusco, Peru, which is the jumping off place for Machu Picchu. And I think it's like 11,000 feet above sea level. So you have to have really good cardiovascular reserve to be there. But he's just built a beautiful facility, working with Chris Becker, who trained with Juan Valle in Dominican Republic. Chris is like a 3rd or 4th generation ophthalmologist from Peru. Chris's grandfather or great-grandfather actually established 2 counties in Peru as being cataract-free zones in the 1980s, and just said there will be no cataracts in these 2 counties. It's a really interesting approach to looking at eliminating blindness, but and so much to learn from that. So with no further ado, Nathan Henson is a physician CEO, alumnus, and he's really been very, very effective at applying the principles at his center. And I'd love to hear your perspectives and your update, Nathan, from what's going on in Peru.
Okay, thank you very much. Share my screen here. Appreciate the opportunity to speak here today. Thank you, Guy, for that introduction. I'm going to tell you, speak a little bit about our experience here in developing a refractive surgery program here in the Peruvian Andes. Start out with showing a little bit of our context. We have some pretty high mountains, beautiful places here. I know when Dr. Kishore comes on, he'll be able to talk about even higher mountains, but we're doing our best here in Cusco. This is me with my children here at one of the wonders of the world we usually mention. So our context, we live and work in a valley at 11,500 feet. So that does affect some of our the work that we do. We have a region of about 1.2 million people with a city of about 500,000. And there's a large influence of tourism here. And I think that is important as we talk about setting up refractive surgery programs in different places in the developing world to consider the market, the context that we're starting with. And I think Cusco has been an ideal context because there is a large influence of tourism, and there are a lot of businesses here in transport, in tour companies, hotels, restaurants, things like that. So there are people with resources that are in this community, while at the same time we have a juxtaposed population with a lot of needy people. And I think that's an ideal situation because it allows us to create a cross-subsidization program that allows us to subsidize the care for needy people. Our needy population are the Quechua indigenous people. These are the descendants of the Incas. And as I mentioned, there are varying socioeconomic levels that helps us with our subsidization program. I do want to take a quick moment to highlight Dr. Becker here. Here's Dr. Becker receiving some cuy, some roasted guinea pig from one of his patients. It's a delicacy here in Cusco after a successful cataract surgery. Dr. Becker's just been outstanding. He's just a great surgeon, a great doctor, a great human being, and I'm just really privileged to be able to work with him. And he's directed a lot of this program from the very start. Just another pictures of our patients. We have patients who come with sheep sometimes and other animals. So our organization is called La Fuente. It's a nonprofit NGO based on the outskirts of Cusco. We have services in ophthalmology, dentistry, and physical therapy. Ophthalmology is definitely the biggest service. We see about 30,000 patients annually. This started out as a potato field, and then the first year we were here, we spent literally building it with our own two hands. I didn't know much about construction before that, but learned a lot in the process. Our mantra for La Fuente is Salud con Compasión, which is healthcare with compassion, and that really is our driving force. We feel like we've been given too much. We've been loved really well in our lives. We've been given too much, and we want to use what we've been given. We want to respond to that by loving people, by providing people with a really high-end level of care that impacts their lives in a really practical way. From the very beginning, La Fuente was started with the idea of state-of-the-art. We wanted to, as others had mentioned, not do this on the cheap. We wanted to provide a service that was absolutely the best possible that we could provide, and that included technology, that includes the services that we provide. Everyone who comes into La Fuente gets what they need. That's our model as well, regardless of their ability to pay. It is based on a self-sustainable subsidizing model, and thankfully we had already developed that over the last decade here that I've been working in Cusco before we started with the refractive surgery program, and that helped us a lot. And we have as a goal for La Fuente training the next generation of healthcare providers, and we're training 2 ophthalmologists, for instance, right now, and every year we take in 2 ophthalmologists for a training program for 1 year. The refractive surgery project actually got started based off a conversation I had in 2017 with a friend who came to visit, and he was just kind of looking around at our facilities and just said, "Hey, do you guys do LASIK? Do you guys do that kind of surgery?" And I said, "Of course not. We're a mission hospital, doing focusing on cataract surgery, blindness prevention." But it did get us thinking. I started to think, why don't we do that? And then just that next year, Dr. Reinstein published work in JCRS about a cross-subsidization project that's already been mentioned in Nepal, and that really inspired us. And then we were able to go to the AAO in Chicago in 2018, and that's where we really met with the Refractive Surgery Alliance. And I can't emphasize how important that has been, that relationship has been, because people like Dr. Kazarian and Dr. Reinstein that helped really hone and focus our vision for what a refractive surgery program could be. We had some ideas, but they really helped us to put some color to that, and also establish great relationships with collaborators from around the world for training, which we're going to talk about. So the design of the refractive surgery project was to create a mechanism for self-sustainability and growth, both of the La Fuente Eye Clinic, but also for the program itself. And then to use refractive surgery as primary vision correction for needy patients. And we've already been doing that, and that's been really exciting to see. We have a lot of patients, for instance, that might make between $100 and $300 monthly, but maybe want to get into the police force or into the military, and we can do this surgery. And right now, they're not allowed to get into that type of work without perfect vision. And so we do this surgery, and we allow them to get into those programs, and then they might make over $1,000 a month. So it's a game changer for them life in terms of their capacity to for schooling for their kids, for getting a piece of land or putting someone through college. So it's a big game changer in that sense. So we do use refractive surgery to impact the needy. And then we want to develop into a training center and subsidize our orphanage work that Dr. Kazarian mentioned. I won't get much into that, but Casa Sofia Orphanage is one of the components of our program. So based in that, our service in laser was born, Instituto Láser de los Andes, this Laser Institute of the Andes. This is a sub-business that we created underneath La Fuente to focus on the refractive surgery program. Now I'm going to talk about some of the challenges that we faced. The biggest challenge that we faced in setting up the refractive surgery program was our knowledge base. We were not classically trained refractive surgeons, and we didn't know what we didn't know. And so that was a big challenge for us to be able to launch a new service. And as Dr. Reinstein mentioned, we knew that if this is a lot of investment, it's a lot of work goes into something like this, and we didn't want to start out with bad outcomes. Because we knew that would kill the project from the beginning. So we needed to get trained. So how did we do that? We started out with trying to improve our knowledge base, and that was through the RSA, the Morris program, the Master of Refractive Surgery. And I was focused on, this involves several components, but I'll focus on two of them specifically. The business and leadership portion, the part that Dr. Kazarian just talked about, was really crucial for us, the physician CEO program, because it is a business, and that we needed to set this up in a way that would be sustainable, that would be quality, that would provide an experience for the patients that was really just delightful, so that they would, so that the program could grow. And so that was really crucial. And then the solutions-based program, I want to focus on the program, the course in London, the forefront of refractive surgery. This was just absolutely critical for us. We've done it 3 times now. Look forward to doing it the 4th time with Dr. Reinstein in London. This really shaped a lot of what we do here in Cusco in terms of the practical part. We also did some training with Dr. Miguel Varas in some didactic training with Miguel Varas in Ecuador. And then we started with the live training program. And that was first with Dr. Reinstein, who was gracious enough to come to Cusco, bring some of his family with him. And he focused with us on standardization, which is just really crucial for any program like this. Down to you can see him here helping us learn how to refract and doing it the same way every time in the correct way. And that was just a big piece of getting us started here. And then we had Dr. Guillermo Rocha that came to help us with screening for keratoconus and managing keratoconus in terms of visual rehabilitation. That was also very important, as I'm going to mention here in a second. And we've done some ICL training with Dr. Andrea Russo in Italy here in 2019, here passed in 2021. Another challenge, as everyone's mentioned, is the cost. This is a big challenge. The cost of lasers, the cost of diagnostic equipment, the cost of surgical instruments, license fees, consumables. How did we manage that? Well, we're still managing that, but one of the most important things, and Dr. Kazarian mentioned this, is the relationship with industry. Industry is really important in this, and we had to develop strategic partnerships, both with Zeiss, who have been really great with us, and with Dr. Rudolf Becker, who's the distributor for Zeiss in Peru. That's allowed us to continue with our program while paying for different services in a way that's doable for a program like ours. Zeiss was really key for a number of reasons. They've helped us with things like click feeds that we'll discuss, but also they helped develop the technology in a way that was applicable for our setting. We are at 11,000 feet. There was a lot of challenges with just how do these lasers work in this context, and they actually redesigned some components that made the technology work better in our location. So just really important to have strategic industry partners. Other challenges that I mentioned, we had some trouble in getting the lasers to us. We had a 20-hour drive from Lima to Cusco through the Andes Mountains. It's not an easy trek, and we actually had one of the lasers get damaged in the process. We had to send it back all the way to Germany and get another one. So that was a big challenge. Low atmospheric pressure, Zeiss had to adjust some of the settings for suction. We had a component of the MEL 90 that the excimer laser the tracking system that was going to swell at low atmospheric pressure that they redesigned, and now all of the machines are now redesigned with that new component. So really, some really cool stuff. And we had some trouble with dry environments, so we have to do a lot of surface optimization. Other challenges, we have a very high rate of keratoconus here in Cusco. Unfortunately, we have a lot of keratoconus here, and so much. We're not a referral center for keratoconus, but we see about 10 to 15 cases every week. And we do a lot of surgery. We have a lot of high cylinder steep corneas. I think our average cylinder is about between 3 and 4. So very steep corneas that don't really necessarily fit with all the normative databases for Pentacam and things like that. So we needed additional technology to be able to screen for patients that were candidates for refractive surgery. And I'll just focus really quickly on the importance of epithelial mapping. That's one of the things we learned from Dr. Reinstein and in some of our training. That's been just absolutely critical for us, having epithelial mapping to screen for the correct patients. And then also having, back service technology, Pentacam, and the ability to do repair treatments, topo-guided treatments with the CRS master system. And we have Presbyon as well. Another challenge was just the fear factor starting in a new fledgling market that we mentioned. There's just a lot of fear that we all know that the number one factor for people not choosing refractive surgery is the fear factor. So we had to manage that by steady plotting, just quality training, as we mentioned, standardization, avoiding errors, optimizing systems, having good technology. COVID was a big challenge that we had. Peru had probably the hardest lockdown in the world that I know of. My kids couldn't come out of our house for 3 months. We had major lockdowns that really put a lockdown on our refractive surgery program. But we did the correct things. We protected our staff. We closed when it was necessary. We had to close down for several months. But the exciting thing is that we're seeing that the refractive surgery program is leading us out of the pandemic. It really is the leader out of the pandemic. And it's really interesting to see how, wearing masks all the time and people with glasses, people hate that. And, it's just really allowing us to come out of it with the refractive surgery program being the leader. I think just to finish, the real principal solution to all of these challenges is relationships. It's relationships. It's doing this together. And this is what this summit is about. And I couldn't possibly thank all the people in this small period of time that have helped us. But these pictures give a little bit of the idea. I mean, we're here with Dr. Einstein's family, with Ursula and Julia and Oscar and Max. And there's a real, it's not just a work relationship. There's a real genuine relationship that's been built. And that's really crucial for us as we move forward together. I feel the same way about Guy and Mary and Guillermo and Pauline and just many other people that we've been able to work with. So doing something like this that seems impossible is possible. Just want everybody to hear that it's possible. And we're living proof of that, but it's possible because of the relationships that we have with these leaders and in our profession, and I'm really grateful for that. So going from here, where we're going to go, we're still training. We're still going deeper with new areas in refractive surgery, and then we really want to be a part of training others. We want to be a training center of refractive surgery. So I hope that we get to see some of you here to teach us more here in Cusco, but also we hope to be part of training future generations. So thank you. I appreciate the opportunity to share.
Thank you, Nathan. That was really inspiring and really a great example of how persistence and determination and passion reign. And really congratulations on all you've done. We look for great things more, and we'll support you every step of the way that we can. Our next speaker is Kishore Van Pradhan. Kishore is a gentleman Nepalese ophthalmologist, a wonderful host, not to invite a bunch of guests to come visit you, Kishore, but it's a wonderful experience to do so. He is one of the many people we have in refractive surgery. I think of Arthur Cummings, Lawrence Coetzee, and others that began in retina and then came to the front of the eye and became involved in refractive surgery. Kishore, having been involved with the Lions Eye Center in rural Nepal and doing other work with HCP and others, decided and agreed to, I think, kind of accepted that we needed a refractive surgeon, and Jeff Taven, I think, and Dan Reinstein were helpful in convincing him of that. He went up and spent a fellowship year with Dan Reinstein, and they work still very closely collaboratively together electronically, virtually. And he's built a beautiful center at the Toganga Eye Institute and is now branched out and is doing other things. One of the things that's really cool about Kishore's model is that he's been able to bring in other alignments. So he's been a real research center, driving research center for new technologies. And this is some opportunities that you can see about, innovating around the edges and looking for ways to create alignment. So Kishore is going to tell us his story about refractive surgery in his part of the world. And Kishore, very grateful for you being here today. Kishore Van Pradhan.
So good evening, everybody. And it's around almost 10 p.m. over here. So I'll say good evening. And thank you, Refractive Alliance, for having me to give a small talk over here. I am just a very small pebble in the feet of very large giants who has been such big names in turning the world in refractive surgery. And I'm also very happy that Matt Oliver is here, because he was the one who was my phaco trainer, many, many years ago. But unfortunately, I'm not in Tilganga anymore. I am with another laser unit. It's called the Matrix Eye Center. But Tilganga, we still have 2 eye surgeons who we've trained. And I'm doing exactly what I was doing in Tilganga. So for the past 3 years, I am in a center called the Matrix Eye Center. Today, these are my financial interests. I'm a consultant to Carl Zeiss Meditech, and I do a little bit of work for Schwind, not now, but mainly for Zeiss. And my objectives today, more than my objectives and what I have to say and my thoughts, I think I have more questions. I have more questions to all the refractive surgeons here. I have questions to people who are not refractive surgeons here. I have questions to my mentor, Dan, probably to God and to everybody in this whole world. Sometimes I think I'm doing very well because everybody tells me I'm doing well. Sometimes I'm thinking, oh, I'm not doing even a bit at all, So my objective today, refractive surgery, this is something I want to tell everybody. Even though we are so many refractive surgeons, sometimes it is so hard for every refractive surgeon to believe that refractive surgery is the main treatment for refractive error and not glasses and contact lenses. So I'll try and make everybody believe that refractive surgery is the main treatment for refractive error. Then I want to talk a little bit on what low cost, high volume, a little bit of revenue generation, and also cross-subsidization and helping other projects in your same institute, and the challenges and how to overcome. I think every surgeon have their own challenges. And me, let's take a scenario over here. So when I ask a question, is a laser eye surgery or cosmetic surgery? Most of the people will say, yes, it is a cosmetic surgery. Sometimes, say about 10 years back, everybody say, no, it is not for the general public. It is for the rich and it's a cosmetic surgery. But for now, it is not. And how? So let's go to Nepal. Nepal is one of the poorest countries in the world. And to think of it, sometimes it is one of the most ridiculous reasons to be blind by not affording a pair of glasses, or life activities being hampered, professional activities being hampered, being not able to do your day-to-day work activity, just being not able to afford a proper pair of glasses. So refractive surgery unit started in Tilganga in the year 2012 by Professor Dan Reinstein, and he trained me there at 2012 January. The unit is still running because we've trained another 2 surgeons. And I, in Matrix Eye Center, I do exactly what I was doing in Tilganga, and probably a little bit more differently. So right now in Nepal, there are 4 centers. There are 4 laser units. There are 2 in the capital in Kathmandu. One is my center, one is Tilganga, and there are 2 centers in the eastern part of Nepal. So these 2 centers in Kathmandu, we have been supported by the laser surgery. Because of our relationships, this have been supported by companies. But the 2 centers in the east are where the people have bought the lasers. And you see the difference, what happens. So let me just start. Now look at this. You see a picture over here. You see a guy lying down with crutches. And you see a person, he is also wearing a pair of glasses. So for me, what I see is I see 2 pair of crutches over here. Let's go for it. A person with a -6, for an example, he's as lame as the person with crutches, because if I ask him to go to the bathroom without his crutches, he will not be able to go. But then again, if you give him his crutches and you tell him to go to the bathroom without his glasses, he will still not be able to go. So a pair of glass becomes his crutches. So this is something I want everyone to believe, that a pair of glasses can really pull you down, pull anybody down. And this is something I want all our refractive surgeons to believe. Unless we believe this, we will never say laser eye surgery is the first line of treatment and glasses are. And again, now wearing glasses -2 or -10 is the same thing. You have to wear them. You cannot go out without wearing a -2 glass, and you still cannot go without a -10 glass. It's the same thing. You still have to wear them. The pain of wearing these glasses are always there. Most of the people in Nepal are born poor. They are born as farmers. They are born as daily wage workers, cooks in small restaurants. They're born as climbers, porters, rickshaw pullers, many of them joining the army, the Indian army, the Nepal army, the British army, and so many similar work. The revenue, the economy of this country, maybe sportsmen, mothers, fathers, grandfathers, students, actors, drivers, everybody wearing glasses can be affected. But now, if you look at this is the same scenario. If you go to UK, US, Canada, South America, Australia, China, everywhere is the same thing. It is not only Nepal, because we are poor, that glasses is a burden, but globally, when you think of it, in every country, wearing glasses is the same pain. Economically, these people will help to boost the economy of this country in a developing world, but also it can hamper the economy of a developed world. Glasses can really pull things down, even in developed worlds. So when you think of it, now, when you have to think, when you want to think of the world where everyone can see perfectly without glasses. As Professor Einstein said it earlier, in India and Nepal, marriages can be canceled because of glasses. It's a genetic disease. Brides can be rejected because of a pair of glasses because their children will have glasses, something like that. So this is such a ridiculous things that happen in India and Nepal. So are glasses the permanent solution? No, they are not. The laser eye surgery is. Yes, let's make us believe that laser eye surgery is the first line of treatment. Phakic IOLs are, clear lens exchange maybe. Is there anything online, people who don't qualify? Probably refractive index change. Something else might be coming up. There might be laser companies thinking more and more, I don't know what. But are we thinking in the line of giving more treatment, making more people free of glasses in this wide world? Can we change lives? In Nepal, where are we now? Where are we? 30 million population of this country. Nepal has 30 million. That is about 0.44% of the world population. How many laser centers? There are 4 laser centers, as I said, 2 in the east and 2 in the center, in Kathmandu. There are 2 femtosecond lasers in Kathmandu, and both of them, they are doing LASIK, PRK, and lenticular extractions. But the laser centers outside Kathmandu, which have been bought by private organizations, they are with microkeratomes, and they're doing LASIK and PRK. Okay? The number of surgeries that we do, we are doing about 1,000 surgeries in Kathmandu. So about 500 in my center, 500 in Tilganga, but they're about doing 100 or 200 surgeries in Eastern Nepal. So do you think we're doing good for my center and for Tilganga? Yes, we're doing very well. But when you look at a country, when you look at Nepal, we are not doing very well. The numbers are very, very low. For a population of 30 million, and you're doing 1,100 to 1,200 surgeries in 1 year, it's not at all adequate. Why? Do you think it is literacy? If you look at the literacy rate, 67% of the people are literate. 78% of the men are. They know how to read and write. They know how to use the internet. They can Google out. They can see doctors and everything. They can find out what is the best surgery to do. Capita income, $900 per year. That's very, very low. Tourism and remittance were the main source of income. But for the past 2 years, it has been zero. But let me tell you, during the COVID time, the number of surgeries I did was the highest. Can you imagine? People would sneak in every day. I would do 3 surgeries every day in my clinic. They'd just sneak out. So money and literacy, I don't think, could be. Every place has a role over there. I don't think it was playing a big role. We are charging less than $700 per smile or smart sight, or even less for LASIK and PRK. And again, the poverty, it is there. People are still bargaining with us. They want to sell off their buffaloes. They want to sell off their cows. So they want to sell off the gold rings or something just to get that extra $100 to get. They need the son to go into the army. They need the son to get a job. They need their daughters to get married, So $100 could affect. But how much? Not too much, a little bit. The real factor, the volume that has not been able to rise, is the fear factor. As Nathan, you mentioned, fear factor, the fear of the general population being scared that something will go wrong and we will not be able to fix it. The fear that you're touching a normal eye and you're going to go blind. There are 4 surgeons in Nepal, and if this guy cannot manage it, the person is going to go blind. And who has been creating this? In my country, I'll tell you. It is our own colleagues, like cataract surgeons who are not doing refractive surgery, retina surgeons, cornea surgeons, optometrists. A cataract surgeon will tell his laser patient, don't do refractive surgery, because afterwards, when you have to do your cataract, your intraocular lens power is going to be erroneous, and you'll land up with big glasses in future. Don't do cataract surgery. When I was doing retina, Dr. Guy, you mentioned I was in retina, I used to tell patients, don't do refractive surgery, because at one point of a time, you might get a retinal detachment. And when I put a lens on your cornea and I start doing refractive, your flap is going to fly out and you're going to be blind forever. This is what I used to tell my patients till I did a cornea specialist who is not doing refractive surgery is going to tell the patient, don't do refractive surgery because you are going to get keratoconus, you're going to get dryness for the rest of your life. The optometrist is going to tell the patient, no, you have to wear glasses. That's the treatment. Okay? They want to sell glasses. That's the main business. This is where we have to change. I've realized over time and time, these are the questions I have for everybody. What is the main thing that we need to change is fear factor. If the person is not scared, they'll get the money from anywhere. The other challenges, environmental factors have never been an issue. Nathan, I think we're very high, we're 1,200 meters, but I've never had issues with suctions, with overcorrection, undercorrection, nothing. Over time, smile is like zoom, such an easy thing. It just went on. Now, traveling has been one of the biggest challenges. Traveling in Nepal can be very, very difficult. There are areas without road. There are people who want to do surgery, but they're very far off, coming to Kathmandu, the cost of staying in Kathmandu. But then with the advent of a smile, I think the follow-ups are so little. You really don't have to follow up too much. So that way, but traveling is very difficult. We know, when you think of Nepal, you think of mountains, you think of the Himalayas. It is difficult. And people are poor. This is something you have to understand. So overcoming the fear, how can we overcome the fear? We can overcome the fear only by training our colleagues. You got to have seminars and conferences and CMEs and get all our ophthalmologists and tell them that refractive surgery is the main treatment for refractive error. It is safe, it is easy, and it is a one-time job. And when you calculate the number of glasses that a person is going to wear for the rest of his life, refractive surgery is going to be a cheaper option than to buy 2 pairs of glasses every year. Now, cost recovery. This is the biggest issue, setting up a laser unit. Do you think I could have afforded a laser unit in my center? No. I would have never been able to afford lasers at the cost of $700 for 2-eye smile if I had not been supported by so many other factors, the laser companies, surgeons, the Refractive Alliance, everybody. This is my question. As I said, I have questions. This is a question, how can we go down? Are there organizations who are willing to work with me? Most of the organizations will not work with me. They will not work with me when I tell them, let's start with a project where laser eye surgery is going to be the main project. But everybody will be ready. Everybody will be ready to say, okay, let's start distributing glasses for free. Let's start doing cataract surgery for free. This is the thing. But then big organizations, big names like big surgeons, it's very difficult for them to change the concept that refractive surgery is the main treatment. So Matrika Eye Foundation, this is besides my laser surgery. So Matrika Eye Foundation is a small charity hospital that was supported by Dan Reinstein. It is a small eye care center in the eastern part of Nepal, which I started 3 years back by my fathers, I would say, Dan, Craig, Glenn, and Tim Archer. They really support. It's a small charity organization in a place called Birganj. I would say London Vision Clinic directly supported that because they gave us the phaco machine and they gave us the microscope, they gave us furniture, and it's a center, they set it up. And indirectly, again, you see, it has been supported by the lasers. In Kathmandu, we do laser surgery, even though it is very, very low cost. We still manage to generate some revenue and then push it into the foundation. In the past 3 years, we have done 8,000 free, I think yesterday it was 9,000 free cataract surgeries done for poor people in a very small place in Birganj. So Professor Einstein just put in a phaco unit. He helped us to build this charity center. And for the past 6 months, this center is self-sufficient. This center does not have a laser unit. But we, from Kathmandu, we managed to support this center. In 3 years, we have done 9,000 free surgeries. And it is a self-sufficient center for the past 6 months. Now the question is again, can I do 8,000 laser eye surgeries in the next 3 years? These are the challenges. Now, since everybody wants, we want laser eye surgery to be the first line of treatment. So now I should be thinking in the next 3 years, I should be doing 8,000 free laser surgeries. I mean, not free, I would say, at a cost that I'm doing, $700 to $800 US dollars. Can I do that? It's very difficult to tell because my costs are very high. I don't know when it's going to stop. If the laser company is not happy with me, I might have to pay a very high cost for the treatment packs. Do you think I can do 8,000 laser surgeries in the next 3 years? Will Zeiss, Schwinn, Zimmer, Johnson, Alcon, Nidec join hands to establish 800 laser units in the world to do 800,000 laser procedures at a very low cost and do 8 million cataract surgeries for free? Do you think it is possible? Now, this is possible only if all we refractive surgeons unite and persuade our laser companies so that we can put in more laser units, do high volume surgery at a low cost, and change millions of lives. I still don't know. This is a question. So we have almost 103 participants. Anybody can tell me, this is a big time debate question. Can we reduce the laser price? Can we reduce the click fees? Can we reduce the servicing? Is there any humanity there? Can we do so many things? Scanning and investigation. Now let's go to ourselves. Are we ready to teach more surgeons? I have taught 2 surgeons. Am I ready to teach another 2 more surgeons in Nepal without considering competition? Fairly right in your heart, I'm going to teach another 2 surgeons in Nepal. Even if my number drops down, I'm okay. No competition, let it be. Even if there's competition, are we ready to teach more refractive surgeons? Am I? I am. This is a question for you. Are you? If you want refractive surgery to be the main line of treatment, you should be training more and more people. With all your heart. How many of us are ready to reduce the cost of the laser cell surgery in your own clinic, in your refractive clinic in the US and the UK and Canada and China, so that more number of people can afford laser eye surgery? If your prices are high, definitely less numbers of people come. Are we ready to reduce the cost of your own laser clinic so that you can double the number of people who can do laser eye surgery and also support preventable, reversible, whatever blind, all the charity works? How can we change lives of millions at a low cost? Refractive surgery is the game. It is the main thing that will support a hospital. So every unit, every eye center should have a proper refractive unit, trained surgeons. Now, the burden in the US, the government doesn't even cover it. There's no insurance for LASIK. Government hospitals have so much a burden for cataracts. NGOs and eye NGOs are begging for money all the time. I know NGOs, I know friends who go from house to house asking for money for years and years to support a charity unit. Can we have a proper refractive unit in an organization that can make the organization self-supportive? In a conclusive note, London Vision Clinic, Professor Dan Reinstein, one person One person from London gets up and says, I'm going to do this. And he's made such a big impact in my country. In me, in my country, my people, thousands of refractive surgeons. Can't we just join hands and make refractive surgery the primary treatment for refractive error? Low volume, low cost, high volume. This is all I have to say for today. So I have more questions. I hope the message is there. This is my center. You see one laser surgery. We do thousands of surgeries, but there are thousands still waiting for us to do. I know Dr. Jeff, Matt, you all do tremendous works. For me, I was called to Africa. I was called to Africa by Dr. Jeff. Let's go to Africa. I said, no, I don't want to go to Africa because I have so much work to do in Nepal itself. I want to do more work in Nepal. I don't have the time to go to Africa. You know, I need to do this here in Nepal. I think you need to do everything in your own country. You have so much to do in your own country. And training is there. How can we do this? I don't know. This is a question to Dr. Guy. Thank you so much.
Thank you, Kishore. That was terrific and very inspiring, and I think very achievable, especially with organizations that come together in a context like this with collaboration. And another one person making this difference is Ashiana. She's the one that brings us together, and it's a great example.
Thank you, Ashiana. Thank you so much.
How this can work. So thank you. I'm going to introduce and turn the program over to Matt Oliva. Matt is known to many of you, of course. Matt's just a beacon of light in the global refractive surgery and cataract surgery arena. He's up in Oregon. He's a professor. He's a fellowship trained person, top institutions, spent time with Jeff Tabin in his fellowship program as a lead board member of the Himalayan Cataract Project, Cure Blindness. He works with Sight Life. He's just everywhere. I don't know how he does it. He's both, and he's all over the world running incredible outreaches. He's opened up ophthalmology in Eritrea after 18 or 20 years of no ophthalmology there recently. He's done work in Ethiopia in a very concentrated way. So just a real example of someone who's getting it done and a good friend. So let me introduce Matt Oliver and turn it over to you, Matt, to take the program from here.
Thank you so much, Guy, and for the very kind introduction. Thank you, Ashiana. And I mean, Kishore and Dr. Henson and Dr. Kutsi, I just salute you for being on the front lines of refractive surgery. And I mean, what an inspiring talks. And I think you've already asked all the pertinent questions to the panel. So I have a great esteemed group here of four experts in refractive surgery and humanitarian care, NGO work, Dr. Ernie, Barbara Ernie in San Francisco, Dr. Dan Dury in Kansas, Dr. Osama Abraham in Alexandria and Cairo, Egypt, and Dr. Simon Holland at UBC. And I'm going to ask them to share their thoughts. And the question I want to pose to the group is, when I was thinking about Kishore's statement, I got to thinking about Nepal in 1990. And in Nepal in 1990, there were approximately 2,000 cataract surgeries being done. And most, quite a few of them were patients who were left aphakic. And if we fast forward 30 years, there's been this dramatic revolution around the world in cataract surgery, in which we've developed, high volume, low cost ways of delivering fantastic outcomes with cataract surgery. And the driving force has been sort of a revolution in delivery models and a revolution in working with industry to get low cost IOLs, reusable phaco tubing. So my question for the panel is, can we achieve the same thing in refractive surgery in the next 30 years? Because we're kind of at the same point we were in Nepal. And what are some specific things that we can do as individuals and as collectively as a group? If you could throw out a few ideas of things that we should be working on now to set this revolution off and running, so that in 30 years we have the same success that we've had with cataract surgery. And maybe Osama, I'll let you're on the front lines in Egypt. Maybe you could share some of your thoughts.
Great. Actually, I would like to thank Shiana and everybody who participated till now. It was an excellent, step ladder approach to the where we are now. I am fortunate to start refractive surgery actually in the very early 90s, as you mentioned, in 1992. And I was inspired by Dr. Akif al-Maghrabi when I worked there. And when I left Yemen and came back to Egypt, I realized that if you want to start a refractive surgery, you have two customers. You have the doctor, and then you have the patient. So our strategy to establish a refractive surgery is to go to a place, team up with the doctors there. They don't have to be real refractive surgeons. They can be any subspecialty, as you all have started. And then we ask them to contribute financially with a very minimal proportion. And maybe we get maybe 50, 60, 70 doctors in one center. And we start by a very rigid regime. First, I was personally responsible for doing the initial cases. So everybody would bring 5 cases to watch them while I'm doing them. He will bring another 5 to assist me while I'm doing them. And I will assist him in 10 cases. And this is repeated with everybody. So by the end of the first year or sometimes second year, we will have 50 to 70 real refractive surgeons. And we have repeated this in 7 areas all over Egypt. And we even extended it to other countries in the Middle East. We did it in Oman, we did it in Qatar, we did it in Bahrain, we did it in Syria. So the idea is to bring doctors together. So nobody will say some bad words or, as you mentioned, some will frighten the patient. On the contrary, everybody will encourage the patient. And when they see the results, they become really convinced that refractive surgery is a frontline strategy for correction. Then I have also to encourage competitors. This is very important. Don't ever think that when another center opens where you are, this will reduce your income or reduce your patient. On the contrary, even it's your responsibility to teach your competitors so their results will be good. Otherwise, they will ruin the refractive surgery if they are not well trained and if they are not following the ethics as Dan illustrated in the beginning of the symposium. So encourage competitors, help competitors, train your competitors. You will gain the respect. They will send you any difficult case that they face. And at the end result, everybody will be a winner. I think with our experience, this can be repeated everywhere. And as also Guy mentioned while he was putting his business plan, number versus cost. This is very important. We usually do at an even less than 700 in Nepal. We do LASIK, standard LASIK with a microkeratome. We do it almost for 300 for both eyes. And for smile, we do it for 500. But imagine if you do 10,000 smiles every year in one center with the price of $500, that's very, very, very profitable at the end. And the same applies to everything. So if you have good volume, good system, also another advice, what we deal with the companies is we pay a very fraction of the price of the instrument as a down payment. Then we have almost 3 months of relief. We don't pay. then we start paying installments, and the center itself from the profits will pay in installments. So in almost all the centers, the initial cost is the only amount of money that the shareholders pay, and everything is self-sustained later on to pay the cost of everything and pay even the installments from machine. So I'm really happy to be part of this symposium today, and I'm really honored to be here, and I would love to share my experience with anybody. And we have faced all kinds of problems that you can see in the last 30 years. So if anybody had any problem or everybody has some advice, I would be more than happy to share our experience with them. Thank you. Thank you, Ashiana. Thank you, everybody.
Thanks, Osama. You're always very generous with your time and advice, and you're very collaborative in nature. So thank you. Dr. Holland or Dr. Dury, would you like to make some comments?
Simon, I've got one that kind of adds on to what Osama said. You know, it takes not only a surgeon, but it takes a patient. And Lorenz, Nathan, and Kishore all mentioned the fact that we have to get the patients to come in. And the one thing I wanted to pass on is something that Kevin Walsh has figured out, because he has a very active centers in Central America. And he struggled through a lot of the almost getting the people not worried about the safety of it, and went through several years of frustration of not getting enough patients. But then he tied in with the local priest, and I was down with him in El Salvador. And what he does is he goes to priests in the local communities and has them send in their blind patients. So the priest is the one that's finding the patients, sends them in, they screen them for cataracts, and then they have a very important system that they do surgery on these patients as a group from that community. They all come in at the same time and they do surgery on Saturday. And the reason they do it on Saturday is then the next morning, very early, and I was part of the surgeon group, we did post-op exams very early, starting at 6 o'clock in the morning. And then all of those patients go back to church. And guess what? The blind see, and then they thank the priest, and the priest tells the priest in the next community to send the patients in because it makes him look good. So I think that's one little trick that I wanted to pass on, is using the religious community to break down some of the barriers for the patients. So I have to thank everybody that's organized this, RSA, ASCRS, Himalayan Cataract Project, and Ashiana for putting this together. This is one of my dreams and has been for a long time. And it's just great to see it moving along, and I'm glad to help in any way I can.
Yeah, I have a kind of a different perspective on some of this, because, you know, first of all, again, thanks for the wonderful meeting we've had, and the hearing these initiatives from around the world has been really enlightening, and I don't want to thank everybody too, and Ashiana for putting us all together. And I was involved in Orbis for 40 years now. I joined out of residency, and many of the lessons I learned in the early days of Orbis can mirror what challenges are going forward with this idea. In those days, we were prevented from attending IAPB meetings because we were promoting, lens implant surgery as a solution for AFA care after cataracts. It was at that level, and it took years to get the evidence and show that, that this was actually a safe approach. We couldn't get our papers published and the whole works. And I see memories of this now. First of all, we've defined a massive problem. We want to know the best way to try and fix it. And I think the only thing few things that I gathered from that experience with Orbis in the first 10 years is that, it's imperative of us to be humble, that we don't have all the answers, that, we are talking to people who have got very fixed views, our professors and so on. And, there are many challenges that were overcome with cataract surgery. The concerns of companies that, if we promoted lens implant surgery, then we'd cut into their, fee-paying markets. That hasn't happened, and these other issues. But it's anything to a plea for us is that we have to get the highest quality of research, and it's thrilling to see how Dan has been successful in his research in London. And we had the pleasure of spending a year with him when he was doing a fellowship with us, and to see how Dan has, really set the bar high for us to get good evidence-based medicine. And I think it's imperative of us that we be modest and kind in how we treat our colleagues, and know this is not something that's going to happen in a rush. But I think that a gentleness in the approach should be good rather than confrontational at all costs. And we've got to realize that people have many different views on our technologies, the best technologies to use, and where the problems are. But I think if we can stay as evidence-based, we can work with, the organizations that do a lot of very difficult work, in the field, in the low-income and middle-income countries. And I think I think it'll be a better experience than it was trying to introduce lens implant surgery. But all the same arguments I heard then, I hear again today. So I guess evidence-based, humility and open, and for us, importantly, to keep an open mind on ways to go forward, and not cling to one sort of central belief and argue it. So I think it's a huge task we take on, and I thank you all for your leadership and wonderful ideas in bringing us together today. Thank you.
Thank you, Simon. Those are great comments. Thank you, Dan, as well. I know we're pressed for time here, but Barb, any final comments, or specifically from the education standpoint with your work with the ASCRS Foundation or nonprofits, on how we can support education around refractive surgery? And
yeah, thank you, everyone. I'm not a refractive surgeon, but a cataract surgeon, and I think we've discussed, getting the patients to come, getting the doctors trained. But as many of us have learned from the cataract surgery, when you have a lot of equipment, you really need the staff trained and technicians trained. And maybe Kishore has some comments on how you're keeping your equipment running in your challenging conditions. But I just wanted to bring up two for kind of everyone to think about that. And I think our next session's addressing that somewhat with education, that it's a team approach. I'm sure even refractive surgery, you do need maybe not as much nursing as cataracts, but certainly the technicians and people maintaining the equipment. So I hope we can find a way to address that also in your talks. And thank you so much, Ashiana, for putting on this such an interesting session today.
Absolutely. Thank you, Barb. Ashiana, I'm going to turn it back over to you.
Matt, thank you so much for heading up the panel discussion. Look, it's an appetizer, right? It's an appetizer because we have so much to talk about and so little time. The history behind this is that we had 8 to 10 different modules, and we've crunched it into one session today. So forgive all of us for running over time, but this is such an important discussion. So with your permission, we will continue on, allowing all of our speakers and panelists to have the opportunity to give in their wisdom and knowledge, and this will also be recorded. So we will move on to the next segment called Equalifying Access, Solutions to Eliminating Refractive Error Through Education. And we're going to start off with Dr. Dan Reinstein on training in the developing world.
Well, my training in refractive surgery started with Simon Holland and Hugo Sutton in Vancouver. And I've been, one of the things that some of us, I've seen, at least some people are not as grateful as they should be to their mentors, and some perhaps a little bit too grateful. Perhaps Kishore, you're a little bit too grateful, but That's okay. I'll take it. So I'm not going to talk for very long on this because I think we've actually touched upon the main points. So hopefully I can just talk a little bit in terms of, what are the key elements to training in the developing world, which is more challenging than using the classical model. And I posted, I don't know how the JCRS would be happy for me to just be distributing a PDF, but there it is. I put it on the chat line, this paper on how we what was the history of how this thing came about in Nepal and this leap of faith that we all took. And it includes a lot of details of what I'm going to just quickly run over here if you want to hear it in more in more detail. Obviously, my financial disclosures, which I talked about earlier. So the classical model, right? I mean, that's the developed world model. The classical model is that you bunch into a 1-year fellowship or 2-year fellowship, you bunch the didactic training, observational and practical wet lab training, then some proctorship of cases and observation, and then, of course, you have connection to your mentors, so you can always write back to them and contact them and call them. That's the classical model. For those of you who have been following the newly formed World College of Refractive Surgery and Visual Sciences, established a few months ago, one of the overarching aims of this organization is to improve on the classical model, because the classical model is just not going to produce the number of refractive surgeons that we need to tackle the actual magnitude of the problem. If we were to do it the way I did it, a year and a half training, forget it. It's scraping the surface. We need to find better ways. I'm not going to provide an answer to that, but I'm going to go over the classical model that we used with Kishore, because we were shooting in the dark, and what we did know, as many of you have already mentioned today, we knew that no matter what, this has to be as best as possible, because if we go even one corner, that could be the one that kills the whole project and makes the whole thing, sets the clock back 20 years again. So theoretical didactic training. So one thing that I've contributed to the community, and you don't mind me say, what's the word that you were using, Simon? I don't know that word very well. It's a humble. Yeah, so I'm not particularly humble about this, because I did spend almost a year setting up this program online for no pay. And that's because I felt a responsibility that there ought to be formalized, high quality, hyper detailed refractive surgery training, because textbooks are, that I've seen so far just don't have the detail, and fellowships, as I said, are just cumbersome ways. So we set up this theory course through the University of Ulster. They had an online educational platform way before this became the norm, thanks to COVID. But this platform's been there for years. Jorge Alio has set up his own system out of his university in Spain, and Guy Kazarian has set up the Master of Refractive Surgery course, which is spread out over a year with some excellent quality speakers and courses. And Aston here in the UK has set up more of an optometry centered system, but of course hugely important to include optometrists in refractive surgery, as the World College of Refractive Surgery and Visual Sciences has defined from the beginning. Optometrists are part of refractive surgery. So we teach our course twice a year. It's finally going back in person. A 4-day, basically we do 5 days work in 4 days. It's a very, very intense. So it's like a 1-week mini fellowship. Again, it's cumbersome. People have to leave their places of work. They have to close their offices. They have to, London's expensive. So it's I don't know. We have a wonderful time, and as Nathan mentioned, I mean, it's a wealth of information that we feed, and people have to come back 3-4 times to assimilate it. Okay, it's good. You've got a textbook. We put down everything we could possibly think about that would be needed by someone who wants to start refractive surgery. into our SMILE textbook. So SMILE is in the middle of it, but there's everything you need to know about PRK and LASIK and diagnostics and pre-op screening and post-op complications. And we put the whole thing into one textbook, even though it's titled SMILE, because we thought that there needs to be a much better, much more detailed, much more granularized explanation as to how refractive surgery can be done safely and repeatably than what we have out there, which is a lot of text with one chapter on this, one chapter, all written by different people, not cohesive, not really a guide to be able to take this. If you read this book and you memorize it, you will be able to start refractive surgery without one lesson from anyone, because everything is in there. Now, it goes to be saying that it's surgery, so you do have to practically train surgeons, and that we're all used to that, so I don't know we can cut that corner much. But we, you know, in our overshoot and overzealous, we cannot fail mode, we had Kishore and Gopal come from Nepal because we needed the guy who was going to be doing the laser programming, who needed to understand all the technical aspects. We needed 2 people to be trained, and we kept them here for 8 months in London away from their families. So that was a big sacrifice on their part. But, you know, here we were training them with a Hansatome, not knowing that we were going to be able to get a Visumax into Nepal. And that was 8 months, followed by a few months of a break where we finally had to work out the time for myself to take 2 weeks out of my schedule, and then Glenn Karp, my associate, to take 2 weeks out of his schedule so that we could provide Kishore with 4 weeks of supervised surgery. And in between, he did no surgery. In other words, there's no see one, do one, teach one. That's not how refractive surgery is taught. We supervised Kishore on 100 eyes, or at least 100 eyes. I think it was 100 eyes I did 100 eyes and Glenn did 100. He did 200 eyes under direct supervision, so that by the time he was left on his own, he was really well trained, and he therefore had a very solid basis to be operating on his own. And of course, you know, we not only trained Kishore, but we trained his entire staff. We had to go through all of the aspects of practice management. We set up an EMR system. Tim Archer set up our Nextech EMR in Nepal so that we had parallel systems. We had to teach them how to answer the phone, customer service training. We had to show them how to flow the patients through the clinic to get the efficiency and the number of cases, and train the technicians on how to use the pre-op diagnostics. So this was this is a global concept of having to get not just the surgeon, but the systems around him and her in order so that they are hitting the road running without complications in the first place. And this was at the end of our first week there, where we felt, it was just a wonderful feeling to see this, and the first patients ever treated in Nepal, with SMILE, and it was really something. Like I said earlier, high standards are the key in refractive surgery. There's no way. What I say to patients is, there aren't 2 ways of flying a 747. There's only just one way. You're not allowed to go, well, I don't do that thing. I like to cut this thing. I switch that off because it bothers me, the beeping. No, if you want to do a 747 your way, you're not going to have a job, because that's not allowed. And so that is what we need to get into refractive surgery. This is totally different from cataract surgery. And everyone does their own thing. Oh, the nucleus, I split it in 3, I split it in 4. No, refractive surgery is engineering. And so the equipment, the methodology, the standardization of the process is paramount to the mass production of something like this, particularly in environments where the follow-up may be somewhat compromised. And so the remote support that we gave Kishore was also a critical component. We were able to log in and look at all of the data on his cases. He would say, I'm not sure if this is keratoconus. We'd log in and say, well, actually, I think it is. Look at the epithelium there. And so he had epithelial mapping before the US had epithelial mapping in Kathmandu. All right, so this is what I'm talking about. We made zero compromise in terms of setting him up. And the first thing we did, although we could have published a paper on how did we do it, said, no. If we do that, This is going to get rejected from the journals. Everyone's going to say, no, it can't be done. No, it can't be done. So we published his outcomes first. This was the first paper that came out. And this was his first 2 years of operation, every eye from eye number 1 to eye number 1,396. And we demonstrated that he was able to get the outcomes that were comparable to the outcomes in the FDA trial. In fact, slightly better, because he had better parameter setting and better technology than what the FDA had restricted on the agreement with Zeiss in their first run, because they could only do sphere in whatever. This was including cylinder, so he had cylinder correction as well. And you can see that he had 80% within a half, and this is myopia up to -10. 60% of the eyes, 2016, myopia up to -10. Okay, and absolute safety. No eyes of this group, including his first eyes in his learning curve, no eyes lost 2 lines of best spectacle corrected vision. It was really a testament to standardization, because yes, Kishore is a great surgeon and he'd already done 10,000 cataracts before he came to me, but okay, you got to start with good ingredients if you want the meal to taste well, but you do also have to know how to cook. And actually, ironically, this was the largest SMILE study published to date when it came out. So not only did we surpass all of the studies that had ever been published before, and there have been millions of SMILE procedures already performed by the time Kishore got in there, but we managed to do the quality control, if you like, with in the public eye, and with a peer-reviewed system, so that there was credibility established from the get-go. And it was then that we decided to publish the method paper, which I have to add was rejected from 2 journals before it was accepted for publication, because there were a lot of motivated competitors who were jealous and were trying to block this kind of concept. And as Simon said earlier, we have to be collegiate about refractive surgery. And as Osama said earlier, absolutely, we want to train our competitors because we want them to be as good as us so that they don't mess up the confidence in refractive surgery. So the message I want to leave you with is you've got to start with the right ingredients. And in our case, we were very fortunate to have started with an extraordinary ingredient called a Kishore. And yes, we published the first papers after this because of his extraordinary capabilities. We published the very first SMILE papers with hyperopia. It was 3 papers that came out of the work that we did with him in SMILE. Then the multi-center trial in Europe came 4 years after this. So we're way ahead of the curve in being able to capitalize on the environment and the expertise of a surgeon there. And then Kishore himself goes and says, wait a minute, I've got an idea. I think I know how to do a sutureless corneal transplant for keratoconus. And he sends me these drawings, and I'm, well, not these, because these were in the publication, but he sent me this hand drawing. I'm like, wow, that, you know what, that actually could work. And we don't even have to ask Zeiss for help, because we're going to use the SMILE program and the FLAP program, and we're going to use a cut down thing, and we can use all these different licenses to create this button and then create the hole. And you're going to shove that extra tissue in through that 2mm incision, which he did. And this is the pre-op astigmatism, 12.46 diopters of astigmatism. And this is 1 year later, 5.4 diopters of astigmatism. And look at that cornea, a big fat transplant in the middle. 2 weeks post-op, crystal clear. I mean, yeah, that's what I mean by superstar, right? The guy is off on his own, is creating science and innovation by himself. We helped a little bit with publishing this and stuff, but so we trained the second surgeon when Kishore left and formed a new organization, and there he is, Shash. And then the third surgeon, who because of COVID hasn't actually been able to come to London to us yet, but she's attended our course online 3 times already. And as Nathan explained, I was delighted to go back to my birthplace. I was born in Lima, Peru. I took my sons to Cusco. They worked at the orphanage for a week, which was a life experience for them. And Nathan and Christian were unbelievable hosts to them and me, and we spent a week. We just had a ball. We went through their first cases and did a proctorship program. And incredibly, look at the way they're setting up. They set up exactly the way we're set up in London. The standardization was was inspiring, awe-inspiring, and training their nurses on where the instruments go, in what order, what angle to hand them to the surgeon, and so they don't have to look up from the microscope. All of the details of training we managed to do in that 1 week. And we're now, delighted that Daniel is from Addis Ababa. He is now taking the Ulster course, and he is going to go to Osama in June, and he'll come to us in the summer. And we're going to hopefully start this whole new concept again through Cure Blindness, through Jeff's organization in September or so in Ethiopia. So the classical model, wonderful, it works great, but sadly, we're going to have to do something better than this. And that's the open question. I don't have the answers. We need to accelerate this training process without compromising the quality of care. That's the challenge to global refractive surgery, is how to produce superb refractive surgery. How do we produce 747 pilots in a 3-month course? Not a year and a half and then 3 years of practicing and fluff and all the stuff that we've had to do up till now. So thank you for that opportunity to sort of give you no answers and just questions.
Dr. Reinstein, thank you so much for that. I'm floored because I feel like, I'm going to have to request you. It's kind of like the Olympics where you have to put in your vote. I have to put in my vote to request you to come now to India and do the same with us. So we are going to move forward to Dr. Giselle Ricoeur, who is at Bascom Palmer Eye Institute. She has a very, very interesting background. She was an ophthalmologist trained in Argentina. She transitioned into health informatics, into that field in US-based telemedicine programs. And when I was told that, who is that person in teleeducation as it relates to refractive surgery, Lisa McIntyre was like, don't even blink twice, it's Giselle Ricoeur. And so we are honored that Dr. Ricoeur is with us. Dr. Ricoeur, handing the floor over to you.
Thank you so much, Ashiana, and thank the entire organizing committee, Lisa and everyone. It's really a blessing to be here with you. You all have such large shoes I have to fill. It's amazing stories we've been hearing, so inspiring, so many leaders and mentors here today with us. It's a challenge to be able to talk at this moment in time, but I just want to take you all out just a bit into the kind of future, but it isn't the future actually, just to think about all the things that we can do and we can start applying. And just for the financial disclosures, our conflict of interest, I am the co-founder of eTouchstone, which is a digital startup that took me to think about how could I best improve everyone's education while not being able to access it like we would all like to do. So having said this, the objectives for today is hoping that you'll be able to understand the role of the emerging technologies that we have in this global medical education, and specifically the pandemic context. It has changed quite a bit, just like Dan was just saying right now. And so that we all can be able to see what the goals would be about being able to train virtually, and then what type of learning vehicles we can actually apply and use for refractive surgery. So first of all, let's talk about medical education and COVID in the sense, and we all know it really impacted the rapid outbreak, really hit everybody. And in order to be compliant with everything that had to do with the social distancing and all the recommendations, the majority of the medical schools worldwide had to transition their curriculum online. And it was like in a matter of a few months. So there wasn't much planning ahead for those that didn't already have it. The ones that didn't really had a tough job before them. Most of the clinical rotations were passed. The lectures and everything went online. We had so many webinars coming out. Some even were kind of like at the same time, the same day. So it was quite complicated. Everything that was surgical for many practices in the sense that the students had to be able to attend the surgeries and so forth, they were also deferred because only urgent surgeries were allowed. And the examinations, we started to have examinations online in those places or countries or cities that weren't used to it. Now, postgraduate training also had a very important impact. And in saying this, many of the residency and fellowships were actually allocated to do COVID treatment. So in this sense, it really impacted negatively. We're talking about 2 cohorts, 2 generations of residents or fellows that had their time to dedicate themselves, for example, to ophthalmology, to refractive surgery, that in many cities and many hospitals were allocated to treat COVID patients. So having taken this into account, which is today's reality, but nonetheless, refractive surgery is still very hard to access on a fellowship basis. And even a residency training basis for ophthalmology. There are many places where there are not enough positions open so that a person could get a high quality education program. So let's talk about teleeducation. And when we use the word tele, we're also very accustomed to thinking about telecommunications, right? But it's the use not only of the telecommunication component, but of the informatics to be able to teach, to learn, to supervise, specifically when both the educator and the learners or the trainees are separated. They're not the same location. And this can obviously be done at any type of level. We're talking about undergraduate, grad, or even continuing medical education. And now today, there are many subspecialty or specialty associations that already have their policies in place in order to favor and support online or remote education. And you can use either asynchronous or synchronous components. It really doesn't matter because it really depends on the scope of what you want to accomplish is the type of technology or learning vehicle that you're going to use. And this is just a small tribute to those that were really pioneers back in the 90s. This was in 1998 for those that may have been there and remember Video Refractive. Roberto Zaldivar, my mentor, and who we started all this movement back in the late 90s about being able to enhance not only our patients' outreach, but be able to educate those that just didn't have the possibility. He hosted 7 live surgeries for training purposes for ICLs. So we're talking about 1998, we're talking about fake IOLs back then, and we're talking about having live audio feed between the surgeon and the different audiences that were mainly in Milan, but the RAI took the signal and transmitted it to other 10 countries. And you're seeing the technology that was available at that time. We were using microwave to be able to get up to the satellite and be able to go all the way over to Italy. And we're seeing how our OR, we had to accommodate with cameras and with all type of technology at that point in time to be able not only to see the surgery, not only to be able to talk to the surgeon, but also to be able to exchange the clinical information about that patient that helped the trainees and anyone, the attendees, be able to understand why we were trying to accomplish what we were doing. So the basic goals of using ICTs in order to be able to enhance our educational process is about increasing access. It's about facilitating actually the knowledge that we all need. It's about being able to improve our decision-making processes, about improving overall our psychomotor skill coordinations. And this is about, and I'll say this many times, and maybe Dan just led us to that question, is accelerating our learning curve, but in a risk-free environment. Think about the aviation. This is not new, but it may be new to us. And it's about sustaining online engagement, about not getting bored, about being systemic in our approach and about being consistent. It's about even being able to practice for rare and critical events. And overall, it's about increasing surgical collaboration and education among different academic medical centers around the world, or with the partnership of all these centers and all these wonderful colleagues that have preceded me and have already done so. So teleeducation, and specifically in these 2 last years, we've seen them grow so fast in these areas. First of all, it was about telemedicine. How could we actually outreach to our patients who were no longer coming in? Or if we were isolated, how could we better attend them? And it's about telesurgery, about telerehab, tele-ICUs. That was a whole different ballgame. We didn't have enough specialists globally speaking to be able to intake that surge that COVID actually brought onto everybody. It was about chronic disease management. All those patients that could not come in, how could we better train to be able to see them and to be able to attend their needs, about remote patient monitoring and behavioral health, which has explosively grown. So For the sake of time, I won't go into much into telemedicine training, but I would like to say that if we don't understand the why we're doing things and how we can actually maintain our not only patient-doctor relationship and the privacy, but the quality of care, regardless of the medium we're using, well, we just don't know how to be able to come ahead and take on the challenges that we have today in modern society. And so now if we go into telesurgery specifically, because we're narrowing in into refractive surgery, it's obviously the use of wireless networking, robotic, and all the immersive technologies we have today to be able to teach and proctor, just like you've been seeing all these examples, but you've been seeing them live in person. I am now challenging you all to think about how can we enable our mentors and our trainees to be able to connect in a collaborative but virtual environment. So we always have to think about, like, for example, if we're talking about healthcare, where your electronic medical record is the foundation of your health information system. If we're talking about an educational information system, you have to think about an LMS, the learning management systems. And those today need new approaches and need new tools. So we have to think of a micro-learning design approach. That's the first step, because this is completely different. This is not sitting in a classroom for 45 minutes. This is about on-demand access to knowledge and being able to get skill transfers or cognitive competencies. It's about having a multimedia library of resources that can help you and aid you best in self-studying. It's about being able to access asynchronous lectures or classes, but also having live discussions, interactive mural posting. It becomes so much more fun to be able to do that. It's about also having your faculty synchronously with you, working and supervising your training encounters. And now it's even about serious games. It's about turning your learning environment into a gaming environment, which actually makes it not only more fun, but much more engaging. And it has the analytics that will help you track your performance. It's about 3D simulations, virtual reality, and also about the possibility of being able to debrief what you've learned, about being able to access online formative assessments, about being able to have accredited certifications, and once again, the learning analytics that will help us all. So serious games are something that are really coming up, and even though they haven't had an enormous impact yet in medical healthcare trainings per se, they have been now. We have more literature coming out on what they're gaining and what they're impacting on patient uptake, for example, in chronic disease management and being able to do treatment compliance and everything. It has been shown that it is very helpful for training. Now, think about the aviation once again. They're used to the simulators, but the simulators do have a cost. They're still cost prohibitive in many parts. But if we do gaming, and if it's on a browser, or we can download onto any one of our devices, and we can be wherever we are, and we're actually accessing the content, and we have different types of ways that we can do that fun. But obviously, where the trend is and where there is a lot of investment going forward is in the immersive technologies, whether they be 3D simulations, web-based, haptic simulations, which are the highest fidelity because you're feeling, you're sensing the pressure, even the temperature. If you're talking about augmented reality or the full immersive virtual experience, these are all the things that are enabling us to be able to interact with what we're doing, and they really are making an impact on the velocity that we can actually gain those competency and those skill transfers. So once again, this is a very different approach to our traditional or classic model, that's just Dan said, about how do we learn. It's about learning by doing and bridging that gap that we have between theories and practice, but in a realistic surgical environment, risk-free. Imagine the amount of times that you can actually, for example, break a capsule and then, or have different types of complications and then just go over them again and go over them again until you really are knowledgeable as to how to be able to better cope with those complications. and you're not on a person, and you're not consuming material, and so it's bringing down the cost, it's optimizing the resources that we all have available. So it gives us a standardized approach. Once again, it's trial and error, and it's risk-free. It's resource optimizing because you don't need as many mentors. You don't need as much room or space for all the simulators, for example. Now we have the virtual headsets that we can use also. It has clear metrics and algorithms that are being built in. And this, what exciting thing could be if we're talking about a collaborative and global setting. Now we do have the challenges. The challenges educators are still thinking about, and this is also published, they're talking about compromising the quality of education if you're comparing it to in-person training. And that's something that Dan just brought up. But I'm not talking about replacing in-person. I'm talking about supporting, supplementing, complementing, because as surgeons, we all know we will need in-person training. Other concerns are the lack of potential bonding or connection between educators and trainees. Believe me, that's the same challenge everyone was saying about telemedicine. You just need to learn how to bond with the other person on the other side of that monitor. And for some, it's the perception that these technologies, that virtual reality, that the robots will overtake our jobs. Once again, they're not here to replace us. It's accessibility, it's bandwidth. Not everyone has the bandwidth, for example, for very high-end solutions for teleeducation. And in these places where it's very cost prohibitive, you have to do proper return on investment analysis for these new training programs. And there's clearly insufficient funding and partnership opportunities yet to expand. So that's why I'm so excited about being part of this program, because I am seeing here so much synergy, so many institutions, so many people willing to partner. So in order to conclude, COVID-19 has clearly highlighted the possibilities for technological advancements within medicine and medical education overall. It's been more than 30 years in some cases of innovation that was actually brought into, in some cases, 3 months over a span of 2 years, that have really skyrocketed everything that we're able to do today compared to just some time ago. But you do need global partnerships in order to be able to address that everyone has the fact or the possibility of access in an equitable way. So just a reminder and to recap, our takeaways today are that the emerging technologies will actually help us train surgeons regardless of where they are in a very rapid way. They actually help us accelerate our learning curve in a risk-free environment. And the hands-on skill transfer of the cognitive and the psychomotor surgical competencies have an unlimited time or number of trial and error sessions. And they're all occurring on multimedia platform, which make it so much easier to engage with. So once again, gaming the micro-learning approach is something we should have in mind, specifically tied to very clear KPIs, using those artificial intelligence and using all the metrics, solution tools that we have today. It will help us continue to improve the outcomes of our curricula. So hopefully in the future, our next meetings will maybe be in metaverse. So this is just a dear thank you to everyone that's been with us today, and to these people that have somehow also inspired me and helped me continue in this new era of ICTs, not only for seeing our patients, but also being able to educate them. Thank you so much.
Dr. Ricord, thank you very much for that inspirational talk. There's much more that is to be done in this realm, and listening to your microwave story, I think it really is inspirational that we can take something from nothing and make it so big. So thank you for that inspiration. We're going to go forward to Dr. Roger Zaldivar. Dr. Roger Zaldivar is based out of Buenos Aires, Argentina, and a dear, dear friend of mine. And when it comes to his talk next, we're really going to focus in on how, we've gone through now teleeducation, right? Teleeducation as it relates to increasing access, but there's also a role in telemedicine in and of itself in refractive surgery, potentially, that in and of itself, it can expand access to refractive surgery for the underserved in other parts of the world, potentially Roger being in one part of the world and me being in another part of the world. And so that component is what we're looking forward to hearing from Roger right now. Roger, I hand it over to you.
Thank you, Ashi. Thank you for organizing this tremendous meeting. I have enjoyed a lot. So I'm going to share my screen. And it's always tough to really talk after Giselle, Dan, and these great speakers. I'm going to try to capture your attention the better I can. But so I'm going to focus more in the practical stuff of telemedicine, what we have learned, and what are we doing now? Because we have been doing this for many, many years. I don't have any financial interest in this presentation. And I like starting with this COVID-19 break, that it really changed the way we do things. It speed up many processes. It was really tough for the world. A lot of people passed away, and many beloved people left. But there are definitely some changes that are going to be positive after this, and that they are going to improve the way we do things. We are going to be much more efficient. We're going to spend less time in things that are not important, and we're going to enjoy more things. And one of the really real things that I believe they are going to change and improve a lot are the unmet needs in medicine. Why I'm saying this? Because medicine is one of those scenarios that are definitely going to change, because a lot of money is being spent there. There are hundreds and hundreds of startups willing to change and improve the way we are doing things. This pandemic has come here in a time where standards were never discussed in medicine in general. And now with the pandemic, everything is a little bit more relaxed. We were able to do telemedicine with WhatsApp. The EMRs are rising and are adding more value to what they used to do, and many, many other processes. So hundreds and hundreds in all the fields, which is very positive. Going back to the topic that I have to speak, of course, is telemedicine. Telemedicine was absolutely everywhere in the pandemic, in every single specialty in medicine, not only in ophthalmology, and even, of course, for dogs, for veterinarians. So it was absolutely everything. But what do we used to do with before this COVID-19? So telemedicine was already applied in more than 3,500 service sites in the US, and over half of all US hospitals have some form of telemedicine. What are the bad news? The bad news before this pandemic there were just a few projects regarding telemedicine. There were a couple of ROP screening, DR screening, and glaucoma screening in some Walmarts, AMD screening, but not more than that. So the question is, what happened with refractive surgery? Where's refractive surgery? Because we can all infer that after all this huge crisis and all these new publications, peer review, after 2019, after this pandemic, will involve refractive surgery. No, the bad news is that there's nothing specifically on refractive surgery. There are some very, very superficial, speaking about corneal screening, but nothing on refractive surgery. So this is a question that I like to attack after with you guys in the discussion, but this is something that has to leave us thinking on this. So we have all the positive, the wing tail. We have patient and provider interest. We have a relaxation of regulatory restrictions, and we do have increased remote care reimbursement. So we have everything positive to start doing this. Most of the EMRs that are being used have solutions, and the ones that do not have any connection, you can use it outside. So there are many, many solutions to telemedicine. It's not an excuse. And now we have many easy to apply solutions like this. I have no financial interest. It's a project from a guy in Argentina. It's very, very good. They are all based with smartphone. That is our biggest tool here. You can see how you can set it up very fast at any slit lamp in the world. There are no restrictions, and it's very easy. And if not, if you want a little bit something more fixed, more sophisticated, you have this project from a Colombian guy living in Germany, which is amazing, that is custom surgical, which is very, very nice too. So we do have the possibility even to be inside our operating rooms with this click and fit technology. So every solution, it's very, very different to what we used to do, what Giselle and my father started more than 20 years ago. Everything was very expensive. They struggled to have the best cameras, the best equipment, to have the best patient experience. But now look at the pictures that can be taken today. These are all smartphone pictures. You can clearly see here in the right, the keratitis. You can see this opacity in the cornea. You see this corneal ring. Everything is very precise and high definition. These are all pictures taken by the smartphone, which means that there's no need today to have a very complex system. It's all a matter of how you set it up, how you train your staff, and how you spend the time, the correct time, standardizing, as Dan Reinstein said, standardizing luminosity and everything to get these spectacular pictures. So this has been proven to be very specific, to have a high specificity and high sensitivity. So besides the cost saving, that they are not something to miss, because this is really one of the most important benefits of telemedicine. I do think that it's much more than that. This is taken into account with expensive equipment. But the most important thing for me is that there is no difference in patient perceived utility. And that's very important. And more if we are thinking in someone that has to elect an elective procedure, to have to pick something to stop using their glasses and correct their vision. They have to feel safe. They have to trust the system. And that's what we have always experienced in the Institute. My conversion rate has always been or equal or better with telemedicine than being live. So as I told you, we have 21 years of experience in the clinic. This started in 2001 in this back and forth with patients. There was one of the 100 economic crises that we have in Argentina every 5 or 10 years. And most of our patients come from Buenos Aires. My father had the necessity to be closer to those patients, being having the highest conversion rate in the clinic. He had this time after doing surgeries to convince patients. And this is mainly what we have been doing in these 21, 22 years. From 2001, we are doing the same, but improving, of course, the flow and everything. And this is what I want to share at a glance in a very short time, at least to feel what we have been doing and to apply it in your places. So if I have to put the 10 more important points on digital transformation: safety. Patients have to feel safe, feel that you are really analyzing exactly their eyes. You cannot say, I'm not seeing very well. Do you have a bad connectivity? They have to look at you and say, oh, everything is perfect. So in order to everything be perfect, you have to take into account details. As it was mentioned before, it's engineering surgery, where here is engineering imaging. You have to have perfect connectivity. Your equipment has to be, everything's perfectly set up. Everything has to be smooth. Engagement, be engaging with your patient, have images, simulations, show them images. It's like a presentation. We are used to do webinars every day. So don't pretend to have a regular standard conversation with the patient. Try to act. It's like a scene of a movie. Satisfaction is very high. It's very convenient by their patients. They don't lose time. And sorry if I'm just anticipating my next couple of slides. Today is much more convenient than it used to be before, because they are not losing time at the examining room. It's much more productive for doctors, for patients, for everyone. It's accessible, it's efficient, and something that is a door opener is we will be able, if we apply this in a more smarter way, we will be able to see patients together, to have collaborative care and to share knowledge. So very fast, in order to finish in time. There are 3 very big groups here. Teleorientation, that has been applied a lot during the pandemic, and unfortunately, it has been abandoned in most of the sites that I know. Immersive telemedicine, that is what we have been doing many, many years, that it can be synchronous, that is seeing the patient in real time, or asynchronous, that is what we are doing, and non-immersive. So basically, immersive telemedicine is feel that you are exactly an extension of the other room. We have same colors, same table, the patient is seeing you at your same size. It's an immersive concept. So you might know this guy, this Diego Maradona, was one of my big patients and big fans of telemedicine. So I had a chance to see him many, many times. And I diagnosed him a cataract, and we performed a cataract procedure on him through telemedicine. So this is not only for poor people, everyone loves it. It's all about the experience that you create. So this is the Cisco story. We are part of a Cisco success case of this application. And I'm not going to spend time on the flows, just tell you that we divided this in 3 parts. The overview and EMR screening, where we check all the data that we have on the patient. We have all the studies. This is what we used to do. The patient encounter, where I have a well-trained technician or OD or a general ophthalmologist, the resident, showing me the eye, and I'm in the other eye. We discuss with the patient and decide for the best idea. Always, I like backing up with images, fundus camera, retinal image, and OSI, objective scatter index, and some exams for dry eye, always good. I'm going to go very fast, not to pass a lot of my time, but I converted 92% of the patients to premium compared to 27% to 73% of the other doctors. So that was the reason why I started doing this with all the patients that were interested in having a procedure, having them listen the explanation. So it's kind of, you are doing both ways, both things at the same time. You are talking to the patient and you are teaching someone. So I'm just going to go fast, very, very fast. Pros and cons. Miss real-time details if staff is not properly trained. This is something very important. If you are not doing this in a synchronous way and you're doing this with only with a recorded image, sometimes they are not focusing ideally in where you would have checked, having the opportunity to command the slit lamp, and the optimization of specialists. This is very, very important. And there is no advantage on flow and time consuming. This is regarding the synchronous. And this is what I want to touch base now. So let me go forward. So now what we are doing, and to be honest, I inspired Neda Nikpur that is there. Neda is a very smart girl and she got it very fast. And she made a comment, and then I started doing this in 100% of my patients. So I'm doing a modular assessment. So far I've seen 2,464 patients this way. And the way I do it is very easy. The patients get to the clinic. We have a series of examinations that we want to do. We want to check absolutely everything. We do the OSI, we check the clinical status, performance, and everything. That patient, that's uploaded to our EMR. I check the EMR, I see absolutely everything. And another day, different day, the patient from his house, with his family, with a coffee, very relaxed. We just talk and spend time together, analyzing their talk and everything. This is a modular way. It's something that in Bascom Palmer, they say hybrid. We have been doing this and it's extremely successful. Sometimes I can even optimize my diagnosis, because if I have doubts in what I'm seeing, I just do first, before doing the consultation with the patient, I just ask the specialist, the retina specialist, what do they think about this? And I earn time for the patient, because at that point I'm giving them a whole decision on their case without having to send him to another place or before seeing. So just, I'm going to finish here, not to make it so long. I think this in the real world, where you have been showing, in most of the places can be applied. There is a scarcity of specialists everywhere, and this is a way to get the specialists to analyze and to add value in places where it can be performed. There is a huge difference in amount of ophthalmologists all around the world. Argentina has one of the highest in the world with 138. And for you to take into account, China has 20 every million, and US has 59, UK 49. Of course, you guys have ODs that we don't have ODs. That's the reason why you have, when you put both together, you have pretty similar to Argentina. But there are places in the world like Ethiopia and other places that have less than 5. So this is the things that we should start envisioning how we can deal with this. As a conclusion, and leaving it to a discussion, I'm not going to repeat all these strategic points that I touched, but I think that modular telemedicine is a valid option for refractive focused practices, higher conversion rate and better patient care. And I think that if we are really committed to cure world blindness, telemedicine should be part of that strategy. That's for sure, not only for screening, for pre-op assessment, for teaching, for mentoring, and for post-op. I think when we think in the amount of time that the patient spends for a post-op, the amount of visits that they have to do, if we can improve all this flow, it will make it easier, as having more surgeons and everything, but it's part of the problem. With this, I'm going to finish and leave it for discussion. Thank you, Ashiana, and all the organization for putting together this great meeting. Thank you very much.
Roger, thank you so much for that. And I am heading to Buenos Aires this year, as well as Cusco. And that's the benefit, right, of community. The idea that we can all learn from each other. And we will be setting up a WhatsApp group for those interested in joining the global refractive surgery community that we are about to embark on. So with that, I would have to say with utmost enthusiasm and excitement that we have an amazing group of panelists coming up next, headed and moderated by my mentor, Helen Wu. Helen Wu is at Tufts New England Eye Center, where I was a medical student. And, you know, we joke in the backdrops that Roshni Bhatt, who's my intern, she's a Tufts undergrad. And then myself, and then Helen Wu, we've got 3 generations. And when you talk about education, right, it's all about passing on that knowledge, that wisdom. And so I am ever grateful to her for everything that she has taught me and inspired me to move on this path. And so without further ado, I pass it on to Helen Wu to introduce and moderate this panel discussion ahead.
Well, thank you so much, Ashiana. Congratulations to you. I am honored to be your mentor, one of your mentors. When you were a medical student not so many years ago, really, at Tufts. And I'm really proud of what you become and the person that you are. And it's wonderful to watch you grow. And this is a testament to your leadership skills and really to you. Congratulations. And I would now like to introduce our panel. Dr. David Chang, president of the ASCRS Foundation and past president of ASCRS. Dr. Hunter Chervak, vice president of clinical services at Orbis International. He helped build CyberSight, its telemedicine platform, and he worked previously with Alcon as medical director of strategic markets. Dr. Netta Nikpour is an ophthalmologist who specializes in cataract, cornea, and refractive surgery at the Aloha Laser Vision. She probably has the best weather of all of us today. She worked at the Himalayan Cataract Project and was a previous recipient, like Ashiana, of the ASCRS Young Eye Surgeon International Service Grant. Dr. Susan Jacobs is Senior Consultant of Cataract and Glaucoma Services at the Agarwal Group of Eye Hospitals. She's also a specialist of refractive surgery, complex corneal and anterior segment reconstructive surgeries, an amazing innovator and amazing educator. And finally, Dr. Lisa McIntyre, who is an ophthalmologist at the Heart of Texas Eye Institute in Austin, Texas. She is the president of the RSA. She is dedicated to providing high quality care to all patients, regardless of economic means. And she is the founder of our RSA Resident Education Webinar Series for the last year and a half, and which really has helped sort of plug a hole where we're lacking resident refractive surgery education. So I'd like to just say a couple words about the background of education in refractive surgery. And Dan and Giselle sort of referred to this classic method of training, and that was really developed in the mid-1800s at Johns Hopkins by Dr. William Halstead and several others, including Dr. Osler. And they basically talked about the triad of knowledge, research, basic science, research, and graduated patient responsibilities over time, such that residents performed increasing complex surgical procedures with supervision until there was a level of independence that was achieved. And that takes time. In high-income countries, the advent of wet labs and surgical simulators has modernized this learning curve, including in ophthalmology. And we've also recently heard now how virtual learning and connectivity can play a role in this education. So how is learning refractive surgery different than learning other surgeries like cataract surgery in ophthalmology? Well, for one, it's not a one-size-fits-all surgery. We have multiple surgeries to choose from. Number two, there's a complex variety of patient factors that determine appropriate candidacy and require accurate interpretation of testing to ensure the safety and appropriate choice of the procedure. Maybe artificial intelligence may play a role in some of this going forward. And number three, dependence on obtaining relatively expensive technology for both surgery and for diagnostic testing, as you've heard from every single speaker today. So Giselle talked about cognitive versus psychomotor surgical competencies. Maybe an easier way to put it is education versus training. It's oversimplified, but education is really defined as the academic broad subject knowledge acquisition, and training is sort of learning by doing. It was typically hospital-based skills acquisition, and it results in specific concrete results that Dan was talking about. And of course, there's an overlap between those two. And there have been a lot of different models of global surgery education and training, some of which are fellowships in global, have resulted in fellowships in global ophthalmology. And those typically involve a collaboration between an academic institution in a high-income country and hospitals in low and middle-income countries. And that often was dependent on travel with the trainees and attending surgeons going to these hospitals in these countries and spending some degree of time, some amount of time there, a week, a month. But in the last couple of years, as you've heard, COVID has completely disrupted this and made us reimagine. And this has become really a blessing in disguise going forward with becoming imaginative in our approaches to education and training. So going forward, we hope to allocate more resources to lower resource settings. And that should be more impactful since locally trained surgeons are more likely to stay local. Just to finish the background, there aren't a lot of papers in the literature about refractive surgery education, but in the surgical training setting, one study in particular identified needs. This was in Tanzania, and given us these anonymous surveys were given to attending surgeons and residents. And these needs include, number one, greater need for didactics. Number two, more clinical mentorship. Number three, longer term presence of visiting surgeons with hands-on training. Number four, more equitable distribution of teaching time. Number five, improved logistical and scheduling coordinations and improved language skills. And finally, increased opportunities for the local people to travel, to learn in other places. So I'd like to now turn to the panel and open it up to them. Dr. Chervak, you have been involved in Orbis and you've helped create CyberSight, which is a large telemedicine platform. What do you see, it hasn't typically included, I believe, refractive surgery, but what do you see and as going forward in learning refractive surgery and employing a platform like CyberSight? And what are the barriers that you've seen in your work with CyberSight?
No, thank you. And it's been a great panel and a great day. So thank you, Ashiana. I think what really CyberSight's about is connection. And I think a lot of the prior speakers said that. Maintaining an e-mentorship. And it's not a grandmother, asking about her grandchild's glasses. It's an expert asking another expert, what do I do with this rare complication or case? And instead of having it be telemedicine, it becomes telementorship. We now have almost 1,000 cases where we've used AI to provide a machine mentoring experience, which is then followed up by a human for posterior segment disease, macula, optic nerve, and peripheral retina. I really like what Giselle said, and I think we take a blended learning approach where certainly we want to maximize the in-presence time of someone like Jeff Tabin or one of these experts with pre-learning on the CyberSight, choose your own adventure e-course learning and standardized webinars like what we're doing today. We do a lot with remote surgical mentorship so that after the doctor leaves, they actually do real-time shoulder-to-shoulder coaching through CyberSight. So for example, when Dan Neely left Mongolia, the doctor's next trabeculotomy was actually done while Dan was in Indiana University and she was in Ulaanbaatar. And then I think the last thing, which obviously we've seen a lot with Orbis, and I've gotten to use some of the flight simulators, I do think low cost, high fidelity simulation is coming to the forefront and is reality. We're doing a randomized clinical trial, thanks to David Chang and the ASCRS Foundation in 7 different countries, looking at our prototype and helping us guide the next version of 2.0. So I guess the answer is there's not one solution, it's blended learning. How do you maximize the communication, the preparation, and the kind of in-country time of an expert like David Chang, Jeff Tabin, all of these great surgeons? I think that's really the key. And how do you maintain that contact through e-mentorship, patient consultation, distance learning, and kind of, as you said, I think Giselle said, gamification. It's going nuts right now with the residents. We're making a World Cup where they're online fighting each other with certain questions. So I think it's really an exciting time to see how training and technology have come together.
Susan, you've been, there are over 100 hospitals, as I think, I've lost count, in the Agrawal Eye Group, and you are the head of refractive surgery, cornea, cataract. How do you expand and amplify education and training across the centers in these different regions where the Agrawal Eye Centers are, and how do you overcome different cultural and educational, or I should say language barriers specifically?
Just wanted to say thanks, Ashiana, for organizing this great evening and this great session here. It's absolutely terrific. And Helen, thanks for that question. So what we do at our institute is every time we take on a new center or we take new doctors, we have a period where they come to our hospital, which is a main hospital at Chennai, and they spend time with us. And the amount of time they spend with us would vary depending on the experience they already have. Invariably, even the most experienced do, however, spend at least a minimum of few days, even if they have many years of experience. If they're absolutely fresh, they may spend anything up to 6 months, from 6 months to a year. If they're a little more experienced, it might be maybe 3 months, needing to do phaco. They do maybe 50, 100 phacos. Even if they've already done it, they kind of learn it again with our system, the way our machines work, the way our nurses are, trained, our systems, our equipment, with all of that, they train all over again. So in refractive also the same thing happens. They come over to our hospital and then they train with us. And then of course, when they go back and they're at their own center, one of the senior people from the main hospital or some other tertiary hospital, which is already well established, they go there and help them to set off. So that's basically it. And we also, of course, have electronic medical record, which is uniform and common across the entire spectrum of hospitals. So any of us can just pull out the case sheet from any other center, be it in Africa or Mauritius or anywhere, and someone has a doubt, we have the WhatsApp groups, different WhatsApp groups. Actually, the phone is crazy. If you look at it, we've got about 1,000 WhatsApp groups. We've got large ones where the entire group is there. Then we've got smaller ones, mid-sized ones, and teeny ones. So we have all these groups and we have all this mentoring that goes on there where, case sheets. The EMR number just needs to be put up and you have all of the data at your fingertips. So you can immediately, instantaneously open it up on your mobile and see it and answer the questions immediately, which I think gives a lot of confidence to the person who's asking the doubt, because he can immediately, tell the patient who's there at the hospital that, okay, this is a plan we have for you. And, we have verified it with more senior doctors, and this is basically the consensus for you. And some of the patients are treated, most of the patients are treated there. Some of them who require a greater degree of expertise are referred to secondary centers or tertiary centers. And that's basically how it is done. We also have, of course, the digital imaging system, cameras, slit lamps, which Roger has shown. It's really very simple. Any resident with a photograph with a camera can just put it against the slit lamp slit lamp binocular and take it. And these images are instantaneously shared, and we are therefore able to give any kind of help that may be required. So I think mentoring is really a big part of our training system, and hand-holding and basically guiding the different new centers, the doctors through the initial stages.
That's amazing. Lisa, you have started to work with residents, and we have a paucity of resident education, and certainly, we're talking about mentorship and skills transfer and training, but what about academic curriculum, a global curriculum? Do we need to concentrate on a global curriculum, or is regional, what are the regional differences, and where does it start? How is it best to do that, do you think?
Gosh, yeah, I think the best thing to do to start is to start. And that's probably how we got all of the knowledge that we have now in our resident training committee. Two of which the residents leading this group are on the call now. I just went Brent Kramer, who started it, and Taj Nasser, who is helping to run it now, are our participants here today, and just have done a tremendous job. And everything that we've learned, we learned on the job. We knew there was a need. Brent stood up and he was like, hey guys, I would like to know more about refractive surgery. I'm not getting it in my training. And we all recognized that problem immediately because we had it too, right? And so we just started. And the intention was, of course, to bring this to everyone around the world. But what we realized pretty quickly is that doesn't land. We do have a global committee right now, and it's helped us to learn that we need to bring a different skill set to people in different areas. So our colleagues in Rwanda who are working with us have different opportunities than our colleagues in the US and in Paris. And what we teach them has to match that. So that's something that we're learning. By no means do I have the answer to that. I think we just keep going. We keep getting better. We keep pivoting and meeting the needs. There'll be a lot of that. I think as we get into, just real quick, twofold. I think as we reach into the developing nations where there aren't already people who have access to refractive surgery, we need to train them where they are. But I think we need to interest them in the first place. I think that's a big part of what the resident teaching series is doing. It's putting this information in front of them that that wasn't apparent before, that there are these opportunities to help people. And yes, you can do it. And it's complex and it's fascinating and it's rewarding. And so, yeah, it's both getting them interested and meeting their needs and training them where they are.
Thank you. Netta and maybe David too. I know you both worked with the Himalayan Cataract Project, and how would you balance coming in and doing mentorship and hands-on training in sort of coming in as a mission versus maybe more virtual learning? Obviously, we need both. But what are your thoughts about regional learning and sort of the amount of time that's needed when you come in on these 1 week missions or 1 month missions, 1 month academic rotations? Netta?
Thank you, Helen. I was going to defer to David, but you said my name. Thank you so much, everyone. This has really been just a wonderful, wonderful program. And Ashiana, great job putting everything together. Before I answer your question, I just wanted to say that symbolically, today is the first day of spring, which is the Iranian New Year. So happy Nowruz to everyone. And I think it's really quite symbolic that this to me really is the culmination of a lot of work that's already happened, but in so many ways is the beginning of something. I think we finally have, an alliance of refractive surgeons who believe that refractive surgery is the way to treat refractive error, and that we believe that it's a right for everyone. It's not just a privilege. It's not something that is only reserved for patients who can pay. It's something that hopefully we can collectively bring to everyone. And, I think your question is really beautiful because there's so much that we all have to teach, yet we all have so much to learn. And what I learned as a global ophthalmology fellow was that, all these places where I was going, I thought, oh, I've done, a Bascom Palmer residency, a Bascom Palmer cornea fellowship. I know all this, theoretical and practical knowledge, but I had so much to learn when I went to places like working with Kishore and, so many others that taught me so much during my fellowship. And you're absolutely right that yes, there's, it's invaluable to have in-person experiences and to be able to actually see how somebody's working in their setting and to collaborate and come up with ideas and, inspire each other to be better. But I think there's definitely a place where we can continue conversations that have already started virtually. And there's so much work that's being done in telemedicine that I think is just really, really inspiring. But there's so many people in the US who, anytime they hear anything about global ophthalmology, they're like, oh, how can I get involved? How can I get involved? And it's not really feasible and practical for so many people to spend, a year of their life abroad, or people like Nathan Henson spending their entire lives serving people in other countries. It's not for everyone, and there are ways that people can help. And so creating a society or creating a place that is a resource for people who have something to contribute, but maybe only have the potential to contribute, an hour every Saturday or Sunday, or whatever time zone they're in. Hawaii, I'm in a very different time zone than you all. We started at 4 a.m. my time. So that means maybe I'm a little bit easier to connect with people who are 12 hours apart from me and 5 hours apart from you, or something like that. I think there's a lot of potential, and just organizing people on this call at least gets us all on the same page, aligned behind the same mission, and allows us to kind of support each other in what we're doing. Yeah.
Thank you. David, what are your thoughts? You've been involved for so long in international ophthalmology. I know you've done a lot yourself. And what are your thoughts about the balance of in-person versus virtual training? And what are your thoughts in general?
Well, just to echo a couple things, I think Kishore, Dan made the point that you have to have patient satisfaction. It's so vital with refractive surgery, unlike some of the other disciplines, because if you don't have patients, all this equipment and training goes nowhere. And I think we all know that some of the challenges are, how do you handle patients that aren't satisfied? I mean, look at multifocal lenses. We all know how to do it. There's a different skill set in handling people that aren't satisfied. And so I think that's where this virtual mentorship that Hunter and Netta just talked about is so important. ASCRS, we as a society have some of the best trained cataract and refractive surgeons in the world. And that gives a potential pool, a very large pool of people that, as Netta said, they don't have to travel, would readily volunteer. They have a wealth of knowledge in terms of how to handle whatever dissatisfied patient. It could be a complication, or it may just be something that isn't medical. And then when you educate them with, as Guy earlier said, that humanitarian care isn't sustainable unless you have some profit. There are really only two profit centers, the optical shop and refractive surgery, that can generate that. So I think that look at this as a huge pool of people that can be put to work as we try to scale this training. And I'm just so excited about having this technology like CyberSight now that can link up this pool of people on the one side and then the people that need mentorship on the other. And I think that's another thing we have to collectively think about is how do we harness that? Because I think, as Netta said, the willingness is certainly there.
Yes. And Hunter, if you could just work out your AI stuff a little bit for the anterior segment, I think we would all be very happy. I know it's a lot more challenging in the anterior segment than it is in the posterior segment for lots of different reasons, magnification and different technology and so forth. But wouldn't it be nice to just plug everything in and say, this person could have PRK, or this person could have SMILE. This person should not have any of those things. They should have an ICL. It would be so nice to be able to put that stuff in. It would help a lot of people. So maybe you could work on that next month and let us know.
How about before dinner? Well, how about before dinner? I'll just get right on that. You want me to just do that small order? Great job on glaucoma, macular degeneration, and diabetic retinopathy. Got to know your audience.
I mean, that's all good. So, but we want refractive surgery.
You guys stop at the posterior capsule. Everything else, forget about it.
Yeah, forget about it. So, all right. Well, thank you so much for all of your thoughts. And I think we probably passed our 10 minutes, but Ashiana, thanks for being generous with the time today.
That was a lovely discussion. And I feel like I'm going to repeat it again. It was an appetizer. For me, I feel like that video recording is one that you're going to have, I'm going to personally have to watch many times over to really take in the pearls. And I feel like there's not going to be any sort of course booklet, textbook like this summit today, where I've learned so much from each and every one of you. A special thanks to ASCRS, to the Refractive Surgery Alliance, to the Himalayan Cataract Project for putting their support on this small pebble of a project, because it's you that have walked the walk. I'm just talking the talk. And I feel like I have become inspired to do some more action from this summit. And I am grateful to each one of you to take time out of your busy schedules to be with us today. The recording will be available for all of us. And a point about the topic of closing remarks was a call to action. And the reason why is because everyone here came in for free, right? Registration was free, but exit is not free. Okay. And so you exit here with a plan. Okay. You exit here today with a thought that, hey, maybe I can get involved in my small way. There is a team of over 5 or 6 undergraduate sophomores, students from Tufts who are behind the scenes. Many thanks to them for putting this together. But it is students who have kicked me in the butt and said, no, we're going too slow. You need to go faster. And so the fact of the matter is that there is every level of training or no training that gets people going and gets us inspired. And so each one of us has a role, whether it be, hey, we're going to pledge to do 10 more cataract surgery, refractive cataract surgeries for those that can't afford in my part of the world, wherever we are, or we're going to add to education, or we're going to build telemedicine. There is something for all of us to do. You could be Dr. David Chang, right? My hero, who's done everything, and I can't imagine he can do anything more. And then I'll say, hey, let's do something more, right? And so that's the point, right? And then you've got me who does nothing. And then you say, all right, let's do something more. So you've got the spectrum, and all of us have to take something back from today, whatever that inspiration is, and do something more, because time is not on our side. And I think Paul Farmer, to start and end with his inspiration, has taught us that in his life, right? That there is not enough time. And as Jeff Tabin said, now is that time. So let us go with that. I thank each and every one of you, like I said, for being here today, taking time out of your busy schedules, and looking forward to many, many more opportunities with collaboration and learning from all of you. So thank you.
Thanks so much, Ashiana. Wonderful job. Honored to be here.
Thank you very much. Thank you.